Good morning, friends. It's a pleasure to have all of you here for this session on practice management. Listen to the Pandit courses
लाइट
on SICS and all that. So let us see what he has to share. Dr. Ravi Trehan.
कोई लाइट का एडजस्टमेंट हो सकता है दैट्स अनोइंग लाइट लाइट डायरेक्शन हो सकती है चेंज इसकी best to chair as I know okay well aware that time given to me is 6 minutes although I can finish my talk in 6 minutes but if it will take 1 or 2 minutes more please do not stop because at the end a 3-minute video is there. So people will not enjoy the flood of happiness hormones if you stopped in between. So it's my request to please give 2 minutes extra for better enjoyment. So I start my talk. I'll cover what is the chemical recipes of the happiness, what one should do and what one should not do. In psychology, this is a state of emotional well-being that a person experience either in a narrow sense or more broadly as a positive evolution of one's life and accomplishments overall, that is subjective well-being. And according to biology of happiness, our happiness is determined by biochemical reactions caused by hormones. This happiness does not come not from experiences themselves but from resulting flood of hormones and electrical signals in our brains. This is a very small exercise, but I'll skip. You can do it at your house because of time paucity. Let's close our eyes for a minute and think about a person or thing you don't like. I'm skipping this exercise. Now think about someone and something you like. Within a minute, flooding of hormones is there, positive as well as negative. A very simple study is carried out. 228 participants were there. A very simple questions: are you happy today or not? And on observation, heart rate is lower level of cortisols in saliva when who are happy. Now, some friends, what they used to say, I'm always unhappy. Will these hormones help me? Yes. Something is neuroplasticity, if you must have heard. This is ability of brain to form and recognize, reorganize synaptic connections, especially in response to learning or the experience or following injuries. So this neuroplasticity is also doing wonders. One, this mechanism of neurofeedback. This is a therapeutic technique that involves real-time monitoring of brainwave activity through an EEG to provide visual or auditory feedback. Our goal is to help individuals learn to self-regulate their brain function, potentially improving cognitive as well as emotional functionings of various conditions. Now I am going to tell about dose. Deep dopamine, reward hormone, O oxytocin, serotonin, and then endorphin. We have made one acronym of dose, so it is really easy to remember. And what to do in case of deficiency of this dopamine? These things happens: procrastination, low self-esteem, lack of motivation, low energy or fatigue, inability to focus, feeling anxious, feeling hopelessness, and mood swings. Okay, now what these reward hormones will give to us? These are associated with pleasurable sensations, eating good food, self-care, and when you accomplish a target. Contrast of bright light in day and dim or no light in night is a perfect cocktail for dopamine release. You can get your dopamine with these. If oxytocin, feeling lonely, stressed, lack of motivation, low energy or fatigue, disconnect of relationships, and anxiety, insomnia. And with this cuddle hormone, promote trust, empathy, and bonding in relationships, having pets around, parenting a plant. Try to socialize rather than to be on social media. deficiency of serotonin, overly sensitive, anxiety and panic attacks, social phobia, obsession, and feel good hormones give helping others, improve digestion, moods, and memory, improve sleep quality, desserts, especially dark chocolates, gratitude list, and deficiency of endorphin, anxiety, depression, aches, pains, impulsive behavior, mood swings, endogenous morphine. This is endogenous morphine, body's natural painkiller it is, which relieves with pain, etc. Stress buster, laughter, workout, and meditation. What not to do? I already mentioned this is dose. Dopamine is unfortunately involved in all reward mechanisms. So, dopamine feedback loop created by social media and smartphones resulted in a kind of addiction to short term gratification, likes, and shares. Up to 73% of people experiencing anxiety when unable to find their phones. Dopamine, too much or too little of hormone can result in serious health issues, Parkinson's, schizophrenia, other mental affections. Remember, it is dose, not overdose. Overdose will kill. Just 3 minutes video, if you can say it's really good, if time permits. Each and every brands, different companies.
बापू कहते हैं
These companies
ये
are,
मैं
yes,
ये यूसुफ लंगोटिया यार सी मेरा लाहौर में हमारे घर के सामने एक बड़ा बाग था। उस बाग का
all
गेट
the hormones will
बाबा
release
आजम
during
ने
this.
रोज शाम को हमने वहाँ पतंगे उड़ानी और उसके बाद जाके यूसुफ के दुकान से जजरिया चुरा के खानी।
झझरिया।
और मेरा साहब नमस्ते।
नमस्ते, मेरी पोती मुंबई वाली।
और बेटे क्या हाल चाल है? बचपन की तंग गली फिर से कूदे फांदे, छोटी छोटी मीठी चोरी गांठ लेके बांधे।
हेलो, अस्सलाम वालेकुम।
फाजिल स्वीट्स।
हाँ जी। दादाजान, दिल्ली से किसी की कॉल है।
हेलो,
यूसुफ अंकल।
कौन?
जी मैं सुमन बोल रही हूँ दिल्ली से, आपके बचपन के दोस्त बलदेव जी की पोती। याद है बचपन में आप दोनों झझरिया चुरा के खाते थे?
बचपन की तंग गली फिर से कूदे फांदे, छोटी छोटी मीठी चोरी गांठ लेके बांधे। एक पतंग सा उड़ता था परिंदों की तरह, परिंदों की तरह, परिंदों की तरह। एक दौर था मन मन मोर था, एक दौर था मन मन मोर था।
पार्टीशन के वक्त हम रातों रात हिंदुस्तान आ गए।
दादू
यूसुफ दी बड़ी याद आती।
कागजों की कश्तियों में डूबा रहता था, झांकती खिड़कियों में उलझा रहता था। वो भी क्या दौर था, मन पे न जोर था। एक दौर था मन मन मोर था, एक दौर था मन मन मोर था।
भैया थोड़ा जल्दी।
मन मोर।
हाँ जी, कौन? हैप्पी बर्थडे यारा। यूसुफ, यूसुफ ओए यूसुफ, मेरे बल्लू ओए।
You are bound to love this because all happiness hormones flooded dopamine, serotonin, oxytocin, as well as endorphins. This takeaway message I'd like to in one slide. For all happiness hormones, what you are supposed to do, make a to-do list and try to accomplish, help others, exercise, yoga and meditation, music and laughter, sleep and exposure to sunlight, socialize rather to be on social media, and last not least, Jadoo ki Jappi. Thank you.
Thank you, Dr. Trehan. That was a wonderful talk. And I know you yourself, you are a very happy, jolly medico. But I think one point is perhaps escaped to mention, if you really want to keep happy, you keep happy your remote control back home. So with this, I invite Dr. Vaishali Vasavda for her presentation on femtosecond laser cataract surgery. Is it worth the investment? Let us see how she makes us happy or unhappy.
Good morning, everyone, respected panelists, my teachers and friends. And this was really the perfect start to a Sunday morning. So much to learn. And now to more, let's say, controversial matters. I will try to justify why I think femtosecond laser cataract surgery even today is a worthwhile investment. And of course, I have me and my practice have financial interest in this. So let's look at first the scientific or the clinical aspect. What we all would love if we start our cataract surgery at this point where the nice rhexis is made, the lens is divided, incision is already pre-made, before you opened the eye or before you did anything, I think that takes a lot of stress away. And like Sir said, a happy life is also a less stressed life. I wouldn't say stress-free life. So that is something, not that you cannot make a rhexis like this. I'm sure most surgeons here will make better than this maybe. But the fact that you can always control that I want this size, I want this centration and this diameter is something that is, I find very useful. The other thing, when the femtosecond laser came in, people just would say that this is a very, very extremely expensive rhexis machine. But that's not true anymore. And now we find that with our platform that we use, the Lensex, even the incisions are excellent. And what we do in a manual incision, you only have a fixed diameter keratome. So you can make a 2.2 or a 2.4. And then if you have to enlarge, you have to manually do that. Now here you can make a perfectly trapezoidal incision, and this is what we do. So the live feed from the OCT, this shows us the junction between the cornea and the sclera, the limbus. So I can position it exactly where I want, anterior, posterior. I can see how much length I want and where I want to enter. So this is what the incision that is going to be created is like. It is perfectly self-sealing. And this is a video of how the incision looks like, very clean, and just use a spatula and this opens up. So even the incisions, now what we like to do is, this is 2.2 and the internal width we make is 2.3. So therefore that the incidence of small descemetes, detachments or little gaping at the wound that used to happen and still happens in manual has reduced quite a lot. And you can see that even after lens removal, this incision here is very, very clean, the internal entry. And so this is what I enjoy more and more now that I'm using the femtosecond laser pretty regularly. Of course, there is no doubt that in a cataract like this, if I have a well-detached rhexis, nothing better than that. Now, some people say, and rightly say, that it is not always that you will get a free cut in a white cataract or an intumescent cataract, but I'm sure Virendra sir will also agree that in 99% cases, there may be one or two small tags which you just can sort of convert with your forceps. So this is something that really I find very useful. And then it has been shown that in complicated situations like in a shallow chamber, it works better than phaco in terms of endothelial cell loss. In posterior polar cataracts, again, using this cylindrical or ring pattern on the machine, you can have lesser posterior capsule rupture. And this is a very recent randomized study we published using from surgeons who had about 5 years experience after their MS. And in there we compared Phaco versus Flax, and we found that Flax had significantly better outcomes in terms of endothelial cell loss and inflammation in the on day 1. Final visual outcome, of course, was the same. So we are not saying you're going to give a very tangible result, but if your safety and comfort increases, there is nothing like that. It is very versatile because now most of the laser platforms, all the companies also have a capability of performing a LASIK flap at least, if not the lenticule extraction. So you can have one laser for both your refractive and your cataract surgery. So that also makes your investment more worthwhile. I think as we are moving forward, patients, more than the doctors, patients are very up to date. Patients, I am sure all of you have heard this AI based surgery and robotic surgery. Do you do that? So they expect that we keep upgrading. They expect that we give them all the options. Whether they choose or not, every time that's their perspective. But we are sort of expected to give them all the available options. Now, I think the single most thing that pinches me and all of us is the cost perspective. But what I feel particularly is that as we move on, most of us are in cities, and there we are not having a bigger pool. It's the same patient pool, and there are more and more people, big hospitals, corporates coming up. So in the same pool, there is more competition happening, and there is a limit to how much the number of surgeries we can increase. So therefore, it works well in that sense also, that you can work same, I wouldn't say less, and then probably earn more. If it's not a bad thing to earn more if you're delivering a good product. People feel that if you talk about cost or earning more, it's an unethical thing. Provided you're not doing anything unethical, there's nothing wrong with making a little more money. And most importantly, will the patients criticize us for charging 40,000-50,000 more over a cataract surgery? So that is, it again is very relative, and there are patients, sometimes it is a social status that I got my surgery in this much, what is your cataract surgery? So sometimes, especially after COVID, I'm personally seeing less of the haggling and bargaining, little bit compared to what it was. And patients are now realizing that they will have to spend more for their health, because COVID particularly has changed a lot in terms of their perception. I think when we talk about practice, now all of these machines, even with an EMI or a bundling, will cost you upward of 2.5 CR. But we are looking at a 10 to 15 year perspective, and that is why I think it also makes sense to share the facility and operating room. We shouldn't have an ego that every practice should have this machine. That will make your investment much more than worthwhile, and so therefore, I feel it is definitely worth the investment. Thank you, sir.
Dr. Vaishali, 2-3 points. One was about the tunnel. You said it is more precise and all that. If you recap, when Phaco was introduced, it was introduced with a recommendation of using a diamond knife.
Right, sir.
And diamond knife tunnel making was as precise as what we do now with the Flex. Number
Sir,
one.
maybe more, I think.
Number one.
Correct.
Number two, one of the important points with Flex is that the CCC is more precise. Do you think till yesterday we were not doing a very precise CCC? One. Two, runaway CCC is there even with during Flex also. If you recap, 2-3 years back we had live surgery in JOS Jaipur. One of the famous Phaco surgeons from South was performing it, and he had a runaway rhexis right there while doing the live surgery. Number three, patient expectation, should we compromise it with increasing prices?
Sir, I think all these points are very valid, and I'm not trying to say that it is superior to Phaco. Probably it is as good as Phaco, or in some things maybe, but there are 2 points. One is it is a little more precise. There is no zero complication rate, like you very rightly said, sir. Even a rhexis can run away, anything can happen. But in an average surgeon's hands, gifted surgeons will do anything as well, but in an average surgeon's hand, the predictability, I think, of the surgery and the ease of the surgery increases more. Now the only problem is the cost, and for which I think it should be blamed for 10-15 years this technology has been, and still they're hiking up the prices instead of bringing it down. So I think that's a very American thing, to make so much money out of that one technology. But if it were more accessible, I think I would, if I have to have a cataract surgery, I wouldn't mind my surgeon doing a flax, even if it is the best surgeon, because I know that it is precise and it is predictable. Nothing is 100%.
Is
But
that predictability is perhaps better with flex. Please collect your certificate from Dr. Virendra Agrawal. And now it's a pleasure to call upon Professor Dr. Kavita Bhatnagar. As you all know, she is head of the department here in AIMS Jodhpur, and she is a dynamic personality doing lot of research work and lot of academic activities and involved in various activities of community ophthalmology also. So, Professor Kavita Bhatnagar.
Okay. Very good morning to all. At the outset, I would like to thank ROS for giving me this opportunity, and thank you, Nepalia sir, for speaking such wonderful words. I don't know how dynamic. Okay, I think this topic is little different from. We always give a lot of emphasis on technical skills, but what I am going to talk today is about people's skills, developing people's skills, which is equally or rather more important. So role of medical humanities in teaching professionalism to ophthalmology residents. In fact, humanities is coming up in a big way. I mean, till now, professionalism and soft skills, they were, part of, considered part of hidden curriculum. But now we have realized that these skills can be taught and should be taught. So I will restrict myself to role of medical humanities in professionalism. Before discussing the methods, just few words about what professionalism is. So professionalism rests on 4 strong pillars of accountability, altruism, excellence, and humanism, which rests on strong foundation of clinical competence, good communication skills, and sound understanding of ethics. Just few words about each of these terminologies. So integrity is unwavering commitment to honesty, ethical conduct, and transparency in all aspects of patient care. Compassion involves recognizing and addressing the emotional and psychological needs of patients. It is much more important to know what sort of a patient has a disease rather than what sort of a disease a patient has. We come across various types of patients. Some are angry, some are anxious, some non-compliant. So we need a certain degree of finesse to handle them. Many times we shout at patients, "You should have come earlier. Could he have?" So we should have empathy towards our patients. What is empathy? Putting yourself in the shoes of patients. We should be accountable for our clinical judgments, treatment plans, and communication with the patients and all our dealings with the patient. And we should respect patients and their relatives and value their rights and beliefs. Excellence is the key pillar of professionalism. So we should continuously strive for excellence, for staying updated like we are doing during this conference. A few words about communication skills. You will be surprised to know that 67% of communication is done through non-verbal communication, that is body language, and words say only 7% out of verbal also. You will agree with me? So now moving on to the methodologies. So these are cinema education, role plays, theatre and forum theatre, role modeling, reflections, case studies, creative writing from scalpel to pen, poetry, artwork, comics and cartoons. So we'll just see what these are. As the name suggests, cinema education is cinema plus medicine plus education. Trigger films, movie clips, video clips, whole length films, can be very effectively used. In fact, this is cinema movies are one of the strongest medium affecting emotions, thinking, professional behavior, and attitude of human beings. Some of the recommended movies are Anand, Still Alice, Dilek Mandir. Shwas was our India's official entry to Oscar Awards in 2004, and I use these movies very often
Yes, sir.
in my teaching.
what is it?
Let us just see this.
A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. What are we going to do about it? Cut it out, man. Cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. I don't...
So we can either use the short clips or the whole movies also on a weekend. Now role plays again foster empathy, communication skills, ethics. Just 1 minute more. It promotes reflection in action and reflection on action, and provides opportunity for formative assessment. I have used role plays and these movie clips very effectively. And this work was published also, and I presented this in first World Summit on Competency Based Medical Education in Barcelona, Spain. Now, role modeling, though it is considered part of hidden curriculum, but it is most effective. Faculty and senior residents serve as role models by demonstrating professionalism in their interactions with patients. So residents not only learn what they are taught, but also what they observe in their mentors' behavior. But we have to be very judicial in selecting our mentors and role models. Forum theatre and theatre of oppressed is gaining lot of popularity in the recent past. And in our FAMER community, we very often use this. And students, experience empathy and learn ethics and professionalism through this. And audience just witness a short play of real life struggles faced by the patients. And participants can also go and enact that and replace them on the stage. Creative writing, some of the tools are reflective diaries, narratives, essays, poems, storytelling, autobiographies, and anecdotes. I think many of us use these in our day-to-day teaching as well. Artwork, comic, and cartoons can also very effectively be used. Some are already available on internet, and you can develop your own as well. Case studies can be combined with other methods. And encouraging residents to engage in self-reflection about their experiences and actions is very effective. And I use this very often with my residents. In fact, we have included this reflection as part of logbook for the residents. So that makes it portfolio. Constructive feedback is crucial for development. As we know, assessment drives learning. And we have used mini CX for evaluation, formative assessment of these skills for residents, which was again published and presented in First World Summit on Competency Based Medical Education in Barcelona. And we saw that there was a statistically significant improvement at the end of 1 year in resident behavior in all the skills. So technical skills are important, but people skills are equally or rather more important. So it only takes a spark to get the fire going, and soon all those around can warm up to its glowing. Thank you for your attention. Any questions?
Thank you, madam, for your wonderful presentation. I mean, these are the practical tips what she has really highlighted. But one thing I would like to share with ma'am is that we expected a lot from residents, but sometimes as teachers, we perhaps don't really match with their expectation. So it's a both-way traffic. While teaching the students, while developing skills in them, we should also be a little more careful than what we see in the present scenario. Thank you once
Actually,
again,
it
ma'am.
is not just for residents, it is for all of us to learn these skills.
That's true.
I
That's
mean,
true.
and we have to be good role models.
But that role model, that's a $1 million, sort of suggestion. Please collect your certificate from Dr. Anil Kothari. Now we have next presentation from one of the stalwarts of ROS, Dr. Virendra Agarwal. As you all know, he is the president-elect of the present ROS executive, and he'll be talking about huge investment in practice. Watch your temperament. Huge investment possible with this gentleman, but let us see what he has to say about the temperament.
Thank you, sir. It is possible only because of blessings from people like you, and which I received from the day one I entered in my practice. And I am thankful that practice management is being covered in ROS. And I think the first talk, the biological happiness, was the biggest thing. My biological happiness comes from the thing that I was from a very middle class family. Me and Kavita were one time neighbor and batchmates, and she has rose to a professor and head. I am still practicing like a single person, but I am lucky now. I have team where people where people are there with me to help me out. But basically, the happiness depends on the kind of psychology you have. There are people who feel happy in doing things. I feel happy in doing the things for which I have been taught, like a medical practice. And the moment I see a patient, I am able to help him, I feel more happy. When I entered in AIMS for my post graduation, the day one comment I listened was, पता नहीं है राजस्थानी लोग क्यों दिल्ली आ जाते हैं. And that was the reason I thought that when I go back, I should do something. By the end of residency, my professor was saying that I am giving you a placement in London, you go there. I said I will go back to my home and I will serve the people there. So that was the reason I started investing. When I started my investing first, I was doing nothing, but the Appasamy helped me. I asked him that I applied for loan, but it will take few days. He said loan hota rahega doctor sahab, aap practice chalu karo. And that is how I started. And since then I feel what all was lacking in Rajasthan should be in Rajasthan, and preferably before somebody else. And that is how we could start LASIK before AIMS in Rajasthan, and that was my most of the happy moments. The practice is not for earning, as Kavita said and others said, Vaishali said. I keep on investing and income is a byproduct. Our aim should be growth, which gives you internal satisfaction. Being doctor, I feel it is my duty that I should offer the best, and for that what I started is that we should have our own existence in our own city, our own state, our own area, in our specialty, not just to have survival, but to have a success. People should know you. And when fame comes, it gives you a happiness at the most. Money doesn't give you. But for that all, you need to do investment. For doing investment, you should be a kind of person which you should know that are you ready to take risk? You are having a money with you which you can invest, or you are having some plans by which you can repay it if you take a loan, or you have a plan by which you can actually don't go bankrupt. So that kind of psychology should be there. You require investment in all stages, whether you are starting or you are established, because when you are starting, you need to show that you can do something. When you are established, you have to take care that nobody goes ahead of you, or you are at least at the same level what your colleagues or peers or near people are doing and what is available, because the patient doesn't come to you only because you may be a skilled surgeon, and surgery alone cannot take you to the heights, because now the specialty ophthalmology is medically it is not a surgical branch alone, it is not a medical branch alone, it is a branch in which we are dependent on supportive instruments be it a diagnostic or therapeutic. And because of this all, what we need is that we need to keep on investing. It is good that your thinking should be balanced. What is required and what you can deliver should be considered whenever you are investing. When you start a practice, what is the best thing to do? You should select a place where you can survive, where you can actually serve longer, and at the same time where the need is there. Then you have to decide what need is the most common need. Is somebody fulfilling that need or not fulfilling? If somebody is fulfilling, then you have to think for some other need. If it is not being fulfilled, then you can start just like a basic surgery of cataract. Basic doesn't mean degrading it. Basic means only that, because we all know the 99% practice is a cataract practice overall. But for somebody it may be 10%, 20%, 30%, depending on the specialty he or she is practicing. And Kavita very rightly said that you need to have a good communication skill with your staff, with your patients, with your family, because otherwise you cannot remain happy. If you say to the patient, तुम क्या ऐसे आ जाते हो, कैटरेक्ट तो कोई भी कर देगा, लेकिन मैं क्यों करूँगा, तो फिर वो पेशेंट नहीं आएगा. The similar way, very simple words I will share. When I joined somebody, I was using somebody's practice to do my surgeries. What he used to say, आपको कैटरेक्ट है, करा लेना. तो मैंने कहा सर आप ऐसे नहीं बोलो कैटरेक्ट है करा लेना, आप बोलो कैटरेक्ट है मैं कब करूं. बिकॉज दिस सिंपल वर्ड्स चेंजेज. कैटरेक्ट है करा लेना मतलब यू गो, एंड कैटरेक्ट है मैं कब करूं मीन्स आई विल डू. सो सिंपल वर्ड्स चेंजेज. एंड corporate I will not discuss, because when you are thinking that it is somebody else's money, you will not put your best efforts. To put best efforts, you should always feel wherever you are working, it is your own or somebody else, that I am the owner of this and I have to survive this. I have to make it profitable, survivable, and it should continue. Then only people will stay, people will come to you, and you will be happy by serving the way you wanted. I am not coming to this that success has happened, so you should not invest. You should keep on investing in your own profession, because to survive your own profession, it is the only way you can do a business. It is not a business in other sense. What I mean is that if you invest in car, if you invest in home, that is a must. I am not saying, but over investment should only be in this. There are people, and Dr. Ravi Trian sir is sitting. I know he is a legendary person for investment into various other platforms. I am trying, and I try to learn that the shares, mutual funds, this what you say property, gold, many other things. But that doesn't give me happiness. I may be having share worth of crores, but that doesn't give me. But having a machine may not be giving the return on investment, but serving persons gives me happiness. So I will request you all that try investing first in your own profession, in your own skill, and based on your skill, you can decide how much you want to invest. Sky is the limit. As I said in the beginning, my father was having a 3,000 rupees salary when he retired, and I had to start my practice. That was the beginning, and today I am happy that I could do something in Jaipur, in Rajasthan, and for myself and my family. And I am getting respect only because of that. I started a new thinking in ophthalmology in Rajasthan. And कोई भी चीज़ बिना रिस्क के नहीं होती है. Even if you do marriage, you may be very happy afterwards, but that is a risk you take to select a new partner, to bring somebody new in your family. It is both sides, be it a girl or a boy, but risk तो लेना पड़ता है. Thank you very much, sir.
Very nice presentation. I just want to add one thing. You must try to have an edge over others in this era of competition, and that you have. Thank you.
In a positive manner.
I think Dr. Virendra has highlighted very important points, how to start and practice and go for the growth. But three things I would like to mention here. You need basically three very important points before you settle down in practice and you start looking for the growth. One, blessings from the Almighty. Two, blessings from your parents and your well-wishers. That is of utmost importance, isn't it? And three, your own aptitude. If you have an aptitude for practice, you will definitely settle down like this gentleman, Dr. Virendra Agrawal. But if you are half-hearted, God bless you. So thank
Sir,
you,
आपने
Doctor.
बिल्कुल सही. I'm lucky to have parents and family with me. And when I started my practice, my all brothers were not doing any other work. Just they were working for me to say to all their knowns that my brother is eye doctor and he has come from AIMS and settling in Jaipur. So please get his services done.
the-
And we were doing it almost free because they were all known. You all know जयपुर में राजस्थान में प्रैक्टिस है कि आपका जानकार आया तो फीस तो नहीं लेनी है. एंड देयर आर डेज आई रिमेंबर जब मुझे पेशेंट बोलते थे सर सारे फ्री देखें आपने अभी तक, मेरे से तो ले लो, आई एम अफोर्डेबल.
That shows the
But-
positive aptitude in this
Yeah.
gentleman,
Yeah.
and we should all have that to settle down in the
And I
practice in long
had a
run.
TV in my house once I started LASIK.
Only thing is, he has forgotten to mention about a big support from her better half, Dr. Anita Agarwal. I request Dr. Trehan to please come over here and collect certificate from Dr. Virendra Agrawal. Trehan साहब का. Now we have our next speaker. He is none other than Dr. Anil Kothari. As you all know, he is ex-president of ROS and is a giant practitioner in Udaipur. So let us see what he has to share with us. Dr. Anil Kothari.
Thank you, Dr. Nepalia. Today I am going to speak on very small matters. We were talking all big investments and everything. They are very necessary in the practice. But apart from that, once you are in practice, you have to care. You have to take care. Very small observation in practice, which will increase or which will highlight your practice. And the things start from OPD itself. Once the patient comes, rightly my previous speakers rightly said that your body language should be very good. Just to welcome, give just a small smile to your patient or relatives, that will aid to your personality. So once you start once the patient comes there, history point what we learn in our old student days. History is very important. You have to listen very patiently, and you have to know it for what patient has come to you. Just ask him what for you have come to me. So this will give a guideline to your diagnosis. Single complaint. Sometimes the patient is speaking 10 sentences, but a single complaint may give you a clue to the diagnosis. So past history, family history, any history of trauma, allergy, medicines, everything you should ask, because these all will help in your diagnosis. Helps you focus your examination also. Whatever he is speaking, if you listen patiently, naturally it will cut short your examination. Indicates when and what investigations are needed. While speaking and while listening, you just make up your mind that what I have to do and what is going on. So helps in determine the functional impact on the conditions of the patients. Now clinical examination. Do not make a very hurry in your making a diagnosis. Just a patient of cataract comes, one eye mature cataract, you just see, put a torch in your heavy outdoor, just put a torch and go for surgery or go for surgery. It should not be there. Mature cataract cases, put a torch and just don't say ask for surgery, because they may have posterior segment features, posterior segment disease also. He may have RD, he may have hemorrhage or any other pathology in the posterior segment. So we should not hurry on the diagnosis. We must investigate patiently. If he has got a cataract in one eye, naturally mature, but you say inner will that we should operate. Immediately we'll just say him get admitted. But we should see the other eye fundus very carefully, and that may give it IOP, and it may give some more information regarding the condition of the patient. May be having diabetes, and you may have some pathology or some retinal changes in the other eye also. IOP may be normal. Inquire about putting anti-glaucoma medicine. Sometimes you have got some clue for the glaucoma patients, but pressure is normal, everything is normal. Still, You may ask the patient, have you, so taking a history I mean, whatever the medicines, sometimes patient may be having some vials of the medicine, that can too give a idea about your disease in the past also. So this type of things, we may miss the many things like ARMD, like glaucoma, other things. If one eye has cataract, examine the other eye fundus, that I already told you. Patient may have a brain tumor also, patient may have diabetes, hypertension, heart disease, many things may be there. Sometimes patient comes with a dilated pupil after consulting some other. So at that time we have to be very careful what was the pupillary reaction and what was the other things which we should have known to before the examination. That first when we start our examination, naturally pupillary action or pupillary reaction gives a very good idea about the diseases. Sterilization is very important thing. Most of the surgeon, we are so busy in our practice that we don't give any attention to the things what is going on in behind. Because check the sterilization room frequently. You should go at least once a week and just go how the sterilization going on, what is the pressure maintained, what is the temperature maintained. We must know it. Don't leave all the things on the staff. Regular swab examination from the theater, it is a must, because sometimes some havoc has occurred and we are in trouble. Watch your assistant while washing the hands before surgery, how they are washing, how they are scrubbing. What we follow is at least 4 minutes washing should be there. So they are very small things, but we must have an eye over others. Teach the staff regarding the importance of the sterilization. During surgery, do not depend on staff completely for biometry and calculation of the IOL power. You may be a very good surgeon, you are doing fantastic surgery, but some refractive surprises may occur afterwards. So one must have on biometry and calculation of the IOL power. I do myself still. Confirm availability of the IOLs. Put a mark on the eye to be operated, as the patient may change some mind. Confirm the eye before you start, because sometimes what happens, a patient comes in outdoor, I'll take 1 minute course, sir. Sometimes patient comes in outdoor OPD and one eye is cataract, another eye is definitely, it may be amblyopic also. So what we suggest, he will insist on that particular eye which has got a less vision, maybe amblyopic. And what we want, the eye who has a very prognosis good, that we want to. Sometimes at the end moment, once your staff says which eye, he just put on the finger on the another eye which is amblyopic, and by mistake you operate, and after that you have to see the results. During and after giving peribulbar block, constantly watch the patients. Be careful, especially once these days we are doing most of the patient in the topical anesthesia, and in the middle of the surgery patient feels pain, and we just want to have the injection peribulbar or retrobulbar, whatever it is. You just you have to be, and we are in hurry because we want to give immediately, because we are in the middle of the surgery, so we want to just push the Jalocan, and patient may go in vasovagal shock. He is under drap, he becomes quiet, you think that the Jalocan has shown his effect, but patient has gone under unconsciousness, and by the time you finish surgery, patient is finished. So you have to be very careful, go very slow, and put a eye over pulse oximeter. Check the emergency medicines quantity and quality, and secondly the date of expiry in your theater. Decide on the table of check the emergency medicines, check O2 cylinders, suction machine, it should be ready in your theater, and should keep a watch. If anything happens wrong, don't be panic and don't shout on the staff and patient, because many of the patients, something has gone wrong and you speak out immediately just by reflex, but the patient is listening and he will attribute it to that particular instance. Even after 6 months, he will say, Doctor Sahab, aisa hua tha, mere saath mein, aisa to nahi hai. So just he will try to correct. So be careful. Decide on table, mode of surgery. Follow up your gut feelings. I mean, if a patient has come, it is mature cataract, it is hypermature, it is a grade 4 cataract, don't go. You can, if your gut says, no, I'll do it SICS and I will give a very good result, don't go for phaco. So it doesn't matter. It is not a question of prestige. It is a question of vision, what you can do for good for the patient. Decide and follow your gut feelings. For pterygium surgery, especially give sufficient time to dry up the graft after use. Sometimes what happens that if you are in hurry, you just paid and bandage, the things were wet, and second day you see no graft is there. It has already displaced. Poor prognosis should be well explained to the patient and relatives. Put a seal on the OPD and admission papers to avoid post-operative confrontation. I just put a mark, the मरीज और उसके अटेंडेंट को अपनी आने वाली रोशनी के बारे में अच्छी तरह समझा दिया गया है. So take home message is giving importance to the minor details may later prevent you major problems. Keeping an eye around us is important. Address the smallest issue in time. Stay calm and patience. Thank you very much.
Thank you, Dr. Anil Kothari. I think you have highlighted very important points. These points hold paramount importance not only for the resident doctors, but for all practicing doctors. Till you are practicing, you have to take care of these points. If you omit these points, you may have to face the music. So I think he has given a very wonderful takeaway message. I request Professor Kavita Bhatnagar to please give certificate to Dr. Anil Kothari.
Pandey sir.
Good morning. Thank you so much, Dr. Virendra Agarwal sir, Dr. Nepalia sir, Dr. Anil Kothari sir, for highlighting the important aspect of ophthalmic practice, and Dr. Trehan sir for sharing the art of happiness. And my talk is the ophthalmic practice in the current era, challenges and opportunity. As we have witnessed the changing trends in the ophthalmic practice, medical practice during the current era, and we have witnessed the right to health movement, RTH bill, which was forced on the doctors, and we have seen how the politicians force doctors to do the work to gain the vote, and it's the dream of most of the ophthalmic surgeons to establish premium ophthalmic practice. The premium ophthalmic practice means the practice of exceptional quality of greater value than others of its kind, and it's a superior kind of services which was perceived as a greater value, greater services, greater results in terms of vision, and overall greater patient satisfaction. In order to establish premium ophthalmic practice, it's very important that we should have the great team, excellent team, as highlighted very nicely by the previous speakers, and we should have access to the latest technology. And team building is one of the most important aspect of building the premium ophthalmic practice. It's very important that we should train our staff periodically. All of us spare time to come to the conferences, get ourselves updated, but our staff needs training periodically. It's very important to train them, send them for training, and do not try to do everything yourself. Supervise it, delegate it to the capable staff, and keep well-trained staff who can multitask between OPD, OT, and reception, etc. And also we need front desk staff and office staff to train in the insurance settlement, which is very important nowadays. The second aspect is the equipment or technology for premium ophthalmic practice. It's very important to invest in the technology for best possible visual outcome. For example, you should have good quality, not only phaco machine, but biometer, surgical microscope, good quality viscoelastic to deliver the best possible results. And it's very important to economize to the extent possible on the interiors and furnishing initially. Initially, it's better to not to spend a lot of money in the furnishing or the building, rather start with the good quality equipment so that you can build your name, and then you can scale up your practice. And it's very important to upgrade your skills. Most of the young ophthalmologists they lack surgical skills sometimes, or they are good in surgical skills. They should observe the established practitioners. For example, Dr. Kothari sir, Dr. Virendra sir, you can spend some time in their setup and see that how they are doing. It's very important to learn from the masters, and you can spend some 2-3 days in their setup. In order to set up the premium ophthalmic practice, it's very important to establish a smooth system and checklist. Checklist is very important. Everything is mentioned very nicely by Dr. Kothari, that you should always double check, do the biometry, mark the eye. These are very small things, but they can lead into serious problems. And sometimes you should also establish a efficient patient flow system from reception, refraction, consultation to minimize the delay. Nowadays, patient wants everything to be done without much delay, and in ophthalmology sometimes it takes time. For example, you explain them if they need fundus examination, every patient should get the complete ophthalmic examination. Sometimes patients are always in hurry कि डॉक्टर साहब बाद में करा लूंगा, मैं तो अभी ये बस ये आप चश्मे का नंबर दे दो. We should always try to convince them that this is very important and you should, it's a part of examination. You are diabetic, so fundus examination is very important. Sometimes they are in hurry and they don't if you don't explain them, they are not going to get it done. It's very important to follow the protocols for premium ophthalmic practice. We should prepare the protocols and implement them in our practice. Documentation and record is very important, and it's very important to prepare the checklist and ensure proper implementation of all protocols and rules and regulations. We have seen that doctors are always a soft target. Many rules, the state regulations and government, the central government are putting a lot of regulations on the doctors. Consumer Protection Act, Drug and Cosmetic Act, Biomedical Waste Management. There are so many rules are there, and pollution control, fire safety. Every year you need to get fire safety certificate. So it's very important for us to follow the rules, because ignorance of the law is no defense. And image building is very important. Marketing with the entry of the corporate sector in the healthcare, marketing became a necessary thing. And you can use the web-based marketing, Google review. Always watch the Google review, and also involve yourself in the professional bodies like IMA, and you can organize some healthcare awareness activities on the important days. And patient satisfaction is very important. The days are gone where doctors are considered next to God. So it's very important to watch the satisfaction, take feedback from the satisfied patient. And if the patient is not satisfied, always listen to them. When any patient comes to you with dissatisfaction, always listen to him or her, and then just try to understand why he is not satisfied. And in order to increase the premium ophthalmic practice, we should always follow some of the tips which I have shared. And in order to increase the number, we should always train our staff, ensure our presence in the online, and this will help us to maximize our experience. Thank you so much for your kind attention.
Thank you so much, Dr. Suresh, for your wonderful presentation. All these things are of great importance in your clinical practice. You cannot overlook all these points. You will be a successful practitioner only after you take care of the points highlighted by Dr. Pandey, Dr. Kothari, and all other previous speakers. So thank you once again. I request you to please collect your certificate.
Thank you, sir. Thank you very much. Thank you.
still waiting for my another two colleagues supposed to be judges. But I think it's getting quite late. If you have any objection, me judging all the video, you may go to the court of law, say one person cannot judge my work. Huh? Okay, then let's start. Who's the first speaker? May I know your name, sir? Gehlot. The management of subretinal hemorrhage with subretinal recombinant tissue plasma activator. RTPA. Is fine. Is there some
Submacular hemorrhage is an uncommon complication of choroidal or retinal vascular abnormalities, including macular neovascularization and polypoidal choroidal vasculopathy. Submacular hemorrhage can damage photoreceptors as a result of iron-induced toxicity, with irreversible retinal injury occurring as early as 24 hours after onset of the hemorrhage. As a treatment, pneumatic displacement of submacular hemorrhage after injection of recombinant tissue plasminogen activator or RTPA in the subretinal space has been described. This video describes the method of preparation and subretinal injection of RTPA using viscous fluid injector system, which is commonly used for silicone oil injection. RTPA is commercially available as vial of 18 mg drug in powder form. It is dissolved in 18 ml of distilled water to get a 1 mg per ml solution of RTPA. Now, 1 ml of this solution in a 2 cc syringe is diluted with equal volume of distilled water. This leaves us with the desired concentration of 50 micrograms every 0.1 ml of solution. This solution is now transferred into a disposable viscous fluid injector syringe, which is connected to the SOI-SOR port of the vitrectomy system. The force of injection in silicone oil injector mode is reduced to 20%. Now the foot pedal is depressed to bring down the volume of RTPA solution in the syringe to 0.5 ml. A cannula with 41 gauge tip is attached to the syringe for the purpose of injection into the subretinal space. The cannula is checked for patency and the volume of RTPA solution is brought down to 0.1 ml by depressing the foot pedal. Now the force of injection is reduced to 5% for final injection. You can see that this force of injection is safe for subretinal use. In this case, the patient has a submacular hemorrhage along with sub-ILM hemorrhage, which is localized at the posterior pole. After complete pars plana vitrectomy, the sub-ILM blood is aspirated after peeling the ILM. Now, RTPA is injected directly into the subretinal hematoma. Subretinal injections of balanced salt solution are given around the hemorrhage to facilitate the displacement of clot away from the fovea and into the dependent parts of subretinal space. SF6 gas tamponade is applied and prone positioning is advised. In this case, after vitrectomy is performed, a massive subretinal hematoma is visible extending into the inferior peripheral subretinal space. The RTPA is injected directly into the subretinal hematoma. No further injections are necessary as there is ample subretinal space inferiorly for the hematoma to move into. SF6 gas tamponade is applied and prone positioning is advised. Pneumatic displacement can be combined with intravitreal anti-VEGF therapy. Although submacular hemorrhage can be challenging to manage, reasonable visual outcomes can be achieved with timely and appropriate intervention. Thank you.
You can clap for him. Well, I have got only one question. What was the post-operative visual acuity?
So the post-operative visual acuity had improved in the first case, but the second case had the hematoma was quite old, so there was white dehemoglobinized blood under the retina. So vision did not improve in the second case. I've got the post-op images because I just the patient came for follow-up recently yesterday, so I got the 1 month follow-up of the first case.
It's okay. It's okay. Just I wanted to know that. May I have the second?
Described by Dr. Ravi Kumar. The sewing machine iridodialysis repair offers many advantages over the previously described techniques for iridodialysis repair. The technique is more safe and less traumatic, requires minimal manipulation in the anterior chamber, more important in patients with phakic clear lens, and thereby it reduces the chances of inadvertent trauma to the capsular bag or lens during the surgery. The technique has the benefit of being more economical by enabling the correction of even a large dialysis with a single suture, offers good post-operative cosmetic results, and is less time-consuming than traditional methods of iridodialysis repair. We had a patient who was a 26-year-old male patient presented to us with post-traumatic limbal perforation with a large area of iridodialysis and a phakic clear lens status with a visual acuity of 20/30. So in this video, we have described the technique of sewing machine iridodialysis repair in a patient who also had the limbal perforation. First of all, the localized peritomy is done at the area adjacent to the area of iridodialysis. The necrotic iris tissue is then abscised. And the healthy iris tissue is deposited back. The limbal perforation is then sealed using the vicryl suture. The bleeders are being cauterized before the creation of the scleral tunnel, which is then created approximately 1.5 millimeters away from the limbus. crescent blade is being utilized for the creation of this scleral tunnel. The pilocarpine injection is followed by the viscoelastic injection, and we are sewing ninoproline into the 26 gauge needle. This needle is then passed through the area of iridodialysis into the scleral tunnel, while the iris is held with the help of the microvitreoretinal forceps. The suture is pulled out and the needle is retracted back into the anterior chamber while creating another loop, and is passed again from the iris into the scleral tunnel. The suture loop is pulled out and the needle is retracted back incompletely, creating the second loop outside into the scleral tunnel, and the suture is pulled out again. This time the needle is completely retracted back outside the wound and the suture is cut. The suture loops are cut and the knots are tied together. You can clearly see the large area of iridodialysis is repaired over here. The anterior chamber is formed and the wounds are hydrated, and the tunnel and the peritomy closure is done with the help of the fibrinized glue. Post-operatively, this is the repaired limbal perforation with repaired large area of iridodialysis, and patient maintains the best corrected visual acuity of 20 by 20.
One question.
Yes.
What advantage does it have with the conventional iris repair?
So I had discussed in the video in the beginning. It is first of all very economical because we are utilizing only one suture for the entire repair. Else would have
By the way, how much one suture cost?
so one suture costs around 580 rupees. So if we are utilizing multiple sutures for just one repair, if we had passed 3 suture knots here, else we would require 3 sutures, so the cost would be multiplied by 3 times. So we are easing out the economical constraints to the patient. Secondly, it is less atraumatic because the AC manipulation is not done again and again. We are only entering the AC once the needle is being retracted back partially and is again passed. Otherwise, we would have to sew the suture all together again, and we need to pass the suture again and again. That's cosmetically it is more beneficial to the patient because there are less suture tying, and it is less traumatic because the sutures are irritating less to the patient. So it has multiple advantages over here.
Okay. You're making such a big incision. There you just make a Hoffman's pouch.
Yeah.
Right? And that's it. Okay.
So, as sir asked, how do you grade like the kind of inflammation you get post surgery in a case when you compare it with the conventional technique?
So we have to prescribe routine post-operative steroids for the patient. If we would do the conventional technique, the steroids would be given over a longer period of time. In this case, since the suture knots are lesser, so we can taper the steroids early, although we do need to give it for 6 to 8 weeks post-operatively.
So you feel the recovery time would be
Is
after
lesser.
Yeah, okay. Sir.
Thank you, sir.
7-year-old female presented with DOB, right hand. 7-year-old female presented with DOB, right eye more than left eye since last 6 months. Her BCB in right eye was CFNF and left eye was 636. Both eyes showed subluxated cataract, which is more than right eye as compared to left eye, with phacodonosis, iridodonosis, and PPM remnants, with vitreous prolapse into AC not touching endothelium. Rest anterior segment examination was within normal limits. She was advised right eye vitrectomy with lensectomy with SF-file endolaser SF6 gas tamponade. We start with 270-degree conjunctival peritomy. A 3-port pars plana vitrectomy with pars plana lensectomy and scleral tunnel incision was marked. Since these pediatric lenses are very soft, they can be aspirated out easily with vitreous cutter. A gentle tricot-assisted PVD induction till mid periphery along with base excision with 2 rows endolaser was done. Sclerotomy sites marked 1.5 mm away from nimbus at 3 o'clock and 9 o'clock. Three-piece PMMA IOL haptics exteriorized with 20 gauge large needle at 3 o'clock and 9 o'clock and ends are cauterized with cautery. In view of iris prolapse in such cases, it is better to externalize the needle over the spatula so as to avoid the needle hitting the iris or getting stuck into the tunnel. After securing the IOL, retinal periphery was checked and fluid air exchange was done. All incisions were closed and air gas exchange with 20% SSC gas was done. Patient came for follow-up after 2 weeks. Her vision was 660. She was satisfied and happy. Thanks everyone for watching.
Dr. Javdi, how old the child was?
7 years.
7 years.
She has bilateral cataract, but the other eye's lens was clear comparatively.
Lens was
But the picture was similar.
But where was the need to sacrifice the posterior capsule?
So there was phacodonosis, iodonosis. There was the lens support was not there. The patient was referred by anterior segment to for that purpose only.
Okay.
They are not comfortable with CTR or sioneering and 3-piece implantation.
Only thing my comment is that after you have put a infusion port, you could have make the section and everything be done, and after that you can easily make second port and third port. And third, when you are doing all the manual, the flow could have been reduced. The iris was coming again and again.
Yeah, sir, because the cannulas are valve cannulas. Yeah. So I told my assistant to switch off when to make the entry, you switch off the infusion so that the iris won't come out. But that was actually late to just make the entry and the iris popped out.
Okay. Thank you. Thank you very much.
Thank you.
Glaucoma blindness rescue operation. We have no financial disclosure. Glaucoma is the second leading cause of blindness in the world. It is a leading cause of irreversible blindness in the world, and it affects more than 70 million people worldwide. In India, estimated number of cases of glaucoma is 12 million, which is around 1/5 of the global burden of glaucoma. By the year 2040, it is estimated that 111.8 million people will be affected by glaucoma. Glaucoma affects 12 million people in more than 40-year above population in India. It's the third major cause of blindness in India. Glaucoma is undetectable and asymptomatic in most of the course of the disease. Therefore, the need of the hour is patient education and awareness for early diagnosis to prevent irreversible blindness. Our initiative on World Glaucoma Week was to increase awareness about glaucoma-related blindness among patients and general population. Our goals were OPD preparations, pamphlet distribution and public lectures, role-play video projection at various places, vision chariot, Drishti Rath in entire Jodhpur city, puppet show on glaucoma awareness, and CME for all doctors. A big innovative rangoli was made at the hospital entrance, which seeks attention of each and every patient. Attractive guard pillars were placed at various places in OPD, which contains pamphlet easily accessible for all patients. Footsteps with glaucoma awareness messages were also placed in OPD. These are the pamphlets with glaucoma-related information and barcodes which can be scanned to access more information on glaucoma. Patient performer were also given to all patients to fill. Multiple explanatory posters were placed on OPD walls. Pamphlet distribution and public lectures were also done for all patients. Role-play videos made by residents on glaucoma awareness were played at various places at hospital. Vision chariot, our Drishti Rath, was flagged off from the hospital which covered entire Jodhpur city. The chariot was decorated with various glaucoma-related posters all around. We had interacted with a large number of general population and educate them about symptoms, severity of the disease and importance of early examination. Puppet show on glaucoma awareness was also conducted in local language.
बाबूजी, मुझे आपकी आंखें देख के लग रहा है कि आपको काला मोतिया की शिकायत हो सकती है। क्या?
A CME was also also conducted for all doctors. After all these efforts, we found a surge in OPD patients for glaucoma checkup. So we have planned more awareness programs, maybe on monthly basis, to reach out to at high-risk population, which is more than 40 years, to educate all patients, door-to-door screening and family screening. Thank you.
Out of all these various measures, which of these you find the most effective?
So, out of all these, the barcode was helpful for the patients and as well as for the relatives. And so the vision chariot also helped us because we did pamphlet distribution via Dishti Rath. So we found the patients are coming and they told us that they met the doctor that time at the time of during. So we found few patients from that also, sir. And the public lecture also, sir, for the patient and the patient relatives also. All the admitted patients in all departments. We organized a public lecture in local Hindi language for them.
Okay.
So these are the some major.
Incidence of 4%. 4% was there, glaucoma.
Sir, in India, I quoted the study done by Ronnie George, sir.
So you
Maybe
should
they're
write
covering the
this.
south.
You should
Indian
write this
population.
is above 40 years. This
Above
is
40
not,
years.
This is not in the general
In general,
population.
yes, sir.
Okay. So we have to target above 40 years.
Above 40, yes, sir.
कठपुतली देखने शायद ही आए वो.
Sir, we did it 2-3 times, sir. So one at the entrance of the hospital for the patients, for the general public, and one at our PHC, one at our main auditorium.
Thank you.
Thank you, sir.
Dr. Kirti Jasing. A 64-year-old male operated for secondary IOL, CMT flex IOL, presented with sudden diminution of vision 1 week post-operatively. On examination, the patient was found to be aphakic with posteriorly dislocated IOL. The temporal haptic was floating in the vitreous cavity and the nasal haptic was still attached to the scleral side. Patient was taken up for pars plana vitrectomy with refixation of the temporal haptic of the IOL. Let's get started with the video. Conjunctival peritomy was done and the previous scleral flaps were exposed. Three 25-gauge pars plana ports were made and the infusion secured in the infratemporal quadrant. Core vitrectomy was done. The vitrectomy was done around the temporal haptic and the haptic was freed of any vitreous. PVD was induced and any leftover vitreous was cleared. During the vitrectomy, the T-shaped haptic was found to be broken, so it was impossible to replace the IOL in the same position as a CMT flex IOL is placed. Only one limb of T was seen. The previous scleral flap was exposed and a separate sclerostomy was made to exteriorize the haptic. Prolene suture was pre-placed around the sclerostomy to tie the broken T haptic and fix it to the scleral tissue. The broken T part was exteriorized through the sclerostomy. However, it was so slippery that it kept on slipping back into the vitreous cavity. Then the temporal loop of the haptic was grasped. A superior limbal section was opened and the loop was grasped with McPherson forceps by handshake technique. Docking of 10-0 proline suture was done through the same sclerostomy. One end was passed below the loop and one end was passed above the loop. Both the ends of the suture were exteriorized. The limbal section was then closed with 10-0 nylon suture. The two ends of proline suture were tied together. The resulting knots were fixed with the sclera by passing one end of the proline suture through partial thickness underneath the flap superiorly. The tension over the suture was kept such that the lens stays centered and no undue tension occurs over the nasal haptic. Pars plana ports were then closed with 6-0 vicryl. Conjunctival flap was reposited and sutured with 8-0 vicryl. Post-operatively, the lens was centered and the patient gained a BCVA of 612. The fundus was normal and the IOP was within normal limits. Thank you.
Any post-op photos?
Sorry, sir, I don't have the post-op photos, so I couldn't put it in the video. But yes, the lens was well centered, as can be seen in the last photograph of the video itself, and it was centered nicely.
Okay, thank you.
An innovative and effective alternative is using platelet-rich fibrin graft. To prepare PRF, blood from patient's antecubital vein using 24-gauge needle was taken immediately before surgery. Blood was then transferred into a clot-free vacutainer and centrifuged at 3000 rotations per minute for 30 minutes. The fibrin clot formed in the middle part of the tube was removed and transferred onto a flat aseptic surface and compressed, and the PRF membrane was thus obtained. Marking of the pterygium head was done. Topical anesthesia was supplemented with subconjunctival lignocaine and adrenaline injection. Pterygium head was removed from the cornea using an iris repositor. Degenerated conjunctival tissue was excised in a well-defined manner. It is important to preserve the normal conjunctiva as much as possible. After tenting up the conjunctiva, Tenon's tissue underneath was bluntly dissected. Oozing of blood was cleaned up using swab stick in between. The adjacent tenons was excised. The residual pterygium tissue was scraped off the cornea with the help of crescent plate. After measuring the scleral bed with calipers, PRF membrane was placed onto the cornea. The graft was measured and trimmed as per the measured dimensions. Trimming off the edges of the graft was done. We noticed that the graft was fitting well onto the host site. With the help of thick fibrinogen and thin thrombin components of the fibrin glue, graft was slided onto the host tissue. After ensuring the placement, smoothing of the edges was done. The graft adhered to the host bed quickly. These are the post-operative pictures taken on day 1, day 7 and 3rd week, where we observed that the graft was stable, well adhered, had minimal local reaction and foreign body sensation. While reviewing the literature, studies showed encouraging results and gave an impression that platelet-rich fibrin is a promising method and has low rates of recurrence and complications. However, long-term follow-up studies are required to understand the advantages of PRF grafting. To conclude, PRF grafting has been done previously in oral, ear, nose, throat, and plastic surgeries, but it is a novel autologous biomaterial for ocular reconstruction post-pterygium excision. It is easy to procure and it reduces the surgical time, preserves the conjunctival anatomy maximally. Its natural fibrin properties allow effective wound healing and tissue regeneration. Thank you.
Thank you. From where you procure this? It's available commercially? What?
No, sir, it is autologous. From patient's blood, we prepared it. I discussed in the video.
Acha, okay. What is the basic material?
So we take blood from the antecubital vein, and then we put it in a clot-free vacutainer. Then we centrifuge it at 3000 rotations per minute for 30 minutes. And then in the vial, three separate compartments are there. One is acellular plasma. In between there is fibrin clot, and beneath it there are RBCs. So the middle part, which is the fibrin clot, we take it out under aseptic precautions, and then we flatten it, compress it to prepare this membrane.
So normal conjunctiva grows on this, huh?
Yes.
You mean to say?
Yes.
How long is the longest follow-up in literature?
Sorry, sir?
How long is the longest follow-up in literature?
So 1 year.
Yours is only 3
3
weeks.
weeks. Yes, sir.
No recurrences.
low recurrence
No,
rates. Yes, less than 1% as per the review of literature.
Okay, thank you.
Management of large angle esotropia. A 20-year-old female presented to us with a squint since early childhood. There was esotropia of 80 prism diopter on examination. Intraoperatively, FDT for medial rectus was 1 plus tight. A Moody locking forceps placed at inferotemporal limbus. An incision circumferential to the limbus made in the fornix. A lateral rectus muscle was hooked with Jensen hook followed by Green's hook. A muscle is dissected from its attachment. A caliper is used to mark a 9 mm point from the insertion. A double arm 6-0 vicryl suture is passed in an interlocking manner from inside out with the needle emerging from the edge of the muscle. A 6 mm point is marked for the future muscle segment length. A single double arm 6-0 vicryl suture is passed at the insertion of the lateral rectus muscle to secure it like an recession of any muscle. The muscle is cut anterior to the resection suture, leaving a stump which was also removed. The resected muscle is sutured to insertion point as planned. And the peritomy is closed with atovicryl suture. The part of the muscle segment is inspected and kept in a saline. Two Moody's locking forceps are placed at the medial limbus and a limbal conjunctival incision is given to explore the medial rectus muscle. A 6-0 vicryl suture is used to secure medial rectus muscle like a recession and the muscle is disinserted. The muscle segment is trimmed till the 6 mm mark. Insertion end of a medial rectus muscle is attached to the free end of the transplant muscle stump with the help of interrupted 6-0 Prolene non-absorbable suture to avoid slippage. The integrity of the elongated medial rectus muscle is checked. The planned recession is marked on the sclera. The insertion end of the lateral rectus muscle transplant segment is sutured to the recession point. Peritomy is closed with the atovicryl suture and the surgery is concluded. Thank you.
How old was this?
Sir, she was 20-year-old patient. That eye is severely amblyopic and other eye was 6/6. So patient was not willing to get her normal eye touch. So she was saying she was full correction with the surgery in one eye only.
Okay. Why the conjunctival dissection differed in two eyes? The one was limbal and one was.
Sir, it was a case of congenital esotropia. So it was long-standing esotropia. So there was conjunctival shortening. FDT it was tight for the medial rectus. So after if the medial rectus FDT is tight, if we go for a fornix incision, so even after the surgery, the tight conjunctiva leads to the underaction of the medial rectus. So it's better to go limbal way and recess conjunctiva slightly so the FDT will get released. It happens during in cases of the congenital squint only, when the long-standing squint leads to the shortening of the conjunctiva. So it's better to recess in surgery, not more than 2 to 3 mm, but it helps in a long-term result.
Okay, thank you.
Okay.
While performing cataract brunescence with leathery posterior pole in a routine OD. While performing cataract surgery, I noticed the rex's size was small, but still we proceeded ahead with the surgery. While taking out the last chunks of the posterior pole as it was leathery, I noticed the capsular bag floating and I felt the pieces were. In this case, I am presenting to you complications faced while performing cataract brunescence with leathery posterior pole in a routine OD. While performing cataract surgery, I noticed the rex's size was small, but still we proceeded ahead with the surgery. While taking out the last chunks of the posterior pole as it was leathery, I noticed the capsular bag floating and I felt the pieces were not coming in the phaco tip, making me realize that something is not right. So at that moment, I realized the danger and I stopped my surgery. After carefully analyzing the situation, as the zonular dehiscence was appearing to be less than 4 clock hours, I decided to go ahead with CTR. So, after deciding, I firstly stabilized the capsule by using iris hooks that were available. After making side port entry, the iris hooks were implanted and the capsule was stabilized. It is often a debatable question: when should one insert a CTR in the eye? Should it be before removal of nucleus or it should be after removal of nucleus? After much analysis, we decided to implant the CTR in after removal of nucleus and cortex aspiration. As post implantation of CTR, aspiration of cortex is very difficult, and if not properly done, it might increase the zonular dehiscence further. So we decided to remove nucleus through wire vectors that was available to us, and the phaco incision were extended and the nucleus piece was removed and the cortex was aspirated. Capsule tension ring is a simple device but is an absolute game changer as it can save the bag. It mainly performs two distinct functions. Firstly, it supports the localized zonular dehiscence and generalized zonular weakness. Secondly, it also withholds optic decentration and tilt of an IOL. Along with it, it ensures there's minimal fibrosis and there is no collapse of the capsular bag. The main prerequisite for introduction of CTR is an intact continuous curvinular capsular axis. After CTR was introduced, it was stabilized by using the handshake technique. But to our dismay, we realized the zonular dehiscence is still present and it has not been resolved. So we went ahead and proceeded with the Sioni ring in the same patient. Sioni ring or modified CTR have an extra eyelet to allow for suture fixation. CTR can be permanently sutured to sclera, indicated for advanced cases of zonulopathy. For fixation of Sioni ring in the eye needs creation of Hoffman pockets through which the Prolene sutures are passed and tightly secured. Secondly, the threading of Sioni ring is needed with 10-0 Prolene suture to provide support, and it also helps in maintaining the position of Sioni ring in the eye. Both the ends of Prolene suture were secured and passed through the Hoffman tunnel and tied, and the Sioni ring was introduced in a similar fashion as the CTR was introduced. Seone ring was introduced in the eye after the threading of needle and fixation of sutures. The Seone ring was placed in the bag. After careful analysis, when no zonular dehiscence was seen in the bag, we thought to introduce the IOL, and it was safely introduced in the eye. Thank you for watching.
Well, end of this long surgery, do you feel you could have gone the some other way?
Sir, I think as a lesson learned from this, I think SICS would be a better approach. It's simple, swift, and very easy. And sir, post-op, I have had my brown cataract. They have next day 6/9 vision. Sir, we often undermine SICS. Temporal SICS, if done adequately, can give you 6/9.
At
Like
least
if
you have got a clear cornea on day one.
yes, sir. And sir, it's very like you can do it in just one go. Sir, it's a very good surgeries.
Yeah, we belong to that era. We
Yes.
jump from ECC to FACO.
Yes, sir.
We don't know how to do SICS. To be very frank. But if you don't know, doesn't mean that it's not a good procedure.
Yes, sir.
I still think every resident, through it learning, must master this technique.
Yes.
Thank you.
Thank you, sir.
Dr. Nidhi, just to add, other than ISIS, because the zonal dehiscence and other things were already there. So what else could have you done other than this the part for the IOL stabilization? Because you planned SICS, even in that, the same things would have been there.
Sir, we have to fixate with COD or CTR or CTS or any all these devices have to be used. And sir, I don't think so we can implant IOL in this bag because sir, we don't know what can happen. So this SICS has to be done prior to this. But if you have landed up this
Planning should
situation,
be there, yeah.
yes, sir. If you have landed up on, if you come across a pre-op that has this ZD, then sir, we need to use these surgical devices, sir. Sir, I don't know other way.
Yeah. Okay, good enough.
Okay, thank you, sir.
Simple and effective technique for complicated and neglected cases of chemical injury. Here, we are presenting a case of a 26-year-old male who had history of chemical injury with lying 10 years back, which was neglected all this while. On examination, we found that there was 360-degree limbal stem cell deficiency with conjunctivalized pannus formation on cornea associated with central granuloma. While performing surgery, first of all, dissection of fibrovascular pannus was done. 360-degree limbal peritomy 3 mm away from corneal margin was started and a plane was created, inside which conjunctivalized pannus dissection was started using Vanna scissor. Pannus is released 360 degree using a combination of blunt and sharp dissection to expose corneal stroma. But while removing, another layer of pannus was observed, which was also separated, maintaining the plane of cornea. After successful removal of pannus, central corneal opacity with haze was examined and further lamellar separation of cornea of 100 to 150 micron exposing stroma was performed using Vanna scissor. Once clear cornea was seen, further dissection was stopped and an amniotic membrane was used to cover the exposed surface of cornea and sclera. Amniotic membrane will act as a scaffold for limbal epithelial cells to grow. Amniotic membrane is oriented basement membrane side up and is secured with fibrin glue. excess of amniotic membrane is excised. To harvest limbal stem cell from the donor eye, we make a mark around 3 mm of limbus. Limbus base conjunctival flap is raised using Vanna scissor and subconjunctival and supratenal dissection is done till the limbal plexus is reached. Sharp dissection is performed. The biopsied limbal tissue is placed over the cornea. Limbal tissue is divided into approximately 6 to 10 pieces. These pieces are placed over the amniotic membrane in a circular manner, avoiding the pupillary area. The tissue are arranged in mid-peripheral cornea, orienting epithelial side up. A drop of fibrinogen is placed over each piece to ensure adherence with amniotic membrane, after which a drop of thrombin is placed over each of these pieces. 1 minute time is allowed for fibrinogen to polymerize and settle. Conjunctiva is secured all around. Therapeutic soft contact lens is placed over the cornea and speculum is removed gently to avoid any traction and dislodgement of the film of the glue. These are the post-op pictures of the same patient. Thank you.
Thank you, Nikhil. When you dissect the cornea, you are in the mid-stroma, literally?
Sir, basically we can say it's an anterior stroma.
Hmm.
Basically, what we do pre-operatively, we do the ASOCT and look for the thickness of the penis and the
You had
cornea.
done a anti-segment OCT.
So in this patient, we did because it was the second or third case were doing, so we didn't do the ASOCT for this patient. We have recorded the video, but normally what we are right now doing, we are doing ASOCT and we are looking for thickness of the penis and
Mhm.
thickness of the cornea. So normally what we are seeing in our routine case, like now routine cases, like we are getting like 350 or 400 micron of cornea is there, and above it's a penis. So we first dissect the penis and try to use the 100 micron guarded blade, and with this we dissect the rest of the 100 micron. If it's a opacity, if it's a corneal opacity, sometimes if the opacity is less, then we leave also, because it has been postulated that limbal stem cells also help in the clearance of this opacity also within a given period of time after 12 months. So right now, what if we are opacity is severe, like in this case, we dissect around 100 micron of the cornea. So we are in the anterior stroma, sir, I think.
Okay, thank you.
Thank you, sir.
Colonoscopy assisted transliminal trabeculotomy in patient with primary angular closure glaucoma. A 38-year-old female with primary angular closure glaucoma post-EAC PI presented to us with an intraocular pressure of 20 mmHg on 6 anti-glaucoma medications and moderate glaucoma. So we had management options ranging from minimally invasive glaucoma surgery to phacoemulsification with or without mix, and more invasive glaucoma procedures like trabeculectomy with mitomycin C. Suture-assisted 360-degree trabeculotomy was introduced by Smith et al. In 1969 and has been part of glaucoma management ever since then. A 50-proline suture is burned with cautery to make its cut end round and more blunt. A side port is made appropriately as to help us push through the trabecular meshwork. The suture is held with the help of a MaxGrip forceps, which is introduced through a side port at the 9 o'clock position. The side port through which the MaxGrip forceps is to be passed is elongated sideways so as to help us maneuver easily. Cohesive viscoelastic substance is used as a coupling agent for Swan-Jacob direct gonio lens, which is helped to visualize the anterior chamber angle. The trabecular meshwork is sliced through with the help of an MVR blade, and the suture with the blunt end is passed through the side port. Now the blunt end of the suture is passed into the trabecular meshwork and pushed with the help of MaxGrip forceps. Care should be taken as to whenever you feel resistance, the further passage of the suture should be stopped. As in this case, you can see as we are pushing through the suture, at this point the suture has kinked and stopped going forward, At this point, we should not be pushing the suture forcefully and should take it out and try another way. That's where the innovative approach kicks in. We have to push the bleeding away from the anterior chamber angle with the help of visco. We made another side port, filled in the anterior chamber with the viscoelastic substance, and passed the suture through the newly made side port. Now, at this point, we decided to push the suture with the help of max grip forceps from another side. The suture was put into the Schlemm's canal in the similar way as it was put before and pushed with the help of max grip forceps. Care is to be taken. You should not feel any resistance while passing the suture through the Schlemm's canal. Any resistance is indicative of suture inadvertently going into spaces other than Schlemm's canal, like suprachoroidal space, which can lead to serious complications. Once we have passed the suture all the way through the Schlemm's canal, now we fill in the anterior chamber with a viscoelastic substance and hold the suture end and pull it in a manner that it creates avulsion of the trabecular meshwork and creates a trabeculotomy. Our efforts in this case are aimed at achieving the maximum amount of trabeculotomy which we can achieve through pulling this suture. After completing the trabeculotomy, we assessed the situation of anterochamber angles and noted there was plenty of bleeding surrounding the angles. So we decided to wash away all the blood from the anterochamber angle so as to ensure that the trabeculotomy doesn't fail. Bleeding from the anterochamber angles was aspirated with the help of irrigation and aspiration cannulae, and the anterior chamber was thoroughly washed off all the viscoelastic substance. Finally, the ports were hydrated. Postoperative follow-up showed that the patient's need for antiglaucoma medication dropped from 6 to 0, and the intraocular pressure remained within desired range. Gonioscopy-assisted transluminal trabeculotomy is an effective, minimally invasive glaucoma surgery for patients with moderate glaucoma and especially young patients. I want to thank all of you for your time and patience. Thank you.
You see, this procedure we usually combined with a phacosurgery.
Yes, sir.
And typically reserved for the where the pressure is not very high,
Yes, sir.
where patient is on one anti-glaucoma or two anti-glaucoma. Here your patient was already on maximally tolerable,
Yes, sir.
but still the results are very gratifying. How you explain that?
Sir, the results of GATT are really very promising, and this was an attempt given before going for more invasive glaucoma procedures. We just wanted to give a trial of conjunctiva sparing procedure, and the initial set of patients which have gone through GATT, they are having really promising results, which we are still following, and we will be.
No, my question is slitting with a 26 gauge needle.
Yes, sir.
Passing suture.
Yes, sir.
And then deroofing it. How the two differs? How the pressure in this case came down so low? I just wanted to know that.
Sir, this creates a 360-degree trabeculotomy. So if we are planning to do a bang or a goniotomy with MVR blade or 26 gauge needle, we usually end up treating just about 70 to 80 degrees of angle. But here we are covering 360 degrees. So it's equivalent to doing 2 goniotomies in a patient, where we have already done primary and secondary goniotomy. And apart from that, even in adult patients, usually the consensus is that the goniotomies don't work because eventually the trabecular meshwork will fibrose after in the postoperative period. But here we pass the sutures throughout and then strip off the trabecular meshwork. So the cleft created, it's that cleft, I think, is the key thing which works better than MVR blade, as MVR blade just creates a slit while this suture creates a cleft. So this is an affordable adaptation from the iTrack device. iTrack is about it's a similar thing, but it is microfiber illuminated microfiber. It has a illuminated microfiber tip about 220 microns diameter. This has about 150 microns diameter. So this is an affordable adaptation from that procedure only.
Where does the basic pathology lies in POAG? Is it in the canal or it's the juxtacanal?
In this case, this was primary angle closure glaucoma. So the theory of this thing is that if we open the angle in primary angle closure glaucoma, then the rest of the drainage channel, we believe that is working fine, but just that the angle, the aqueous is not getting enough space to pass through the angle. In POAG cases, so this is where the randomization will come. If we follow up in further patients, will it work in the POAG patients or not? That's the question which will arise, because in POAG patients the further drainage channel is also not working properly. But in PACG patient, we believe that just the angle part is the thing which we need to treat. That's why the LI works, because we just need to treat the angle. Just need to give the aqueous some space to go into the angle. So even further, if we have also created a cleft in the angle.
I fully agree. My basic doubt remains same. LIG is also when you want to bring down the pressure about 3 to 5 millimeter. Huh?
Yes.
It will not bring down the pressure 40, 50 to 14. This is not possible.
So the pressure in this case was well maintained on the anti-glaucoma medications only. Just 6, yes sir. 5 topical and 1 capsule IOPAR was also used.
Thank you.
Thank you, sir.
23-year-old male with past history of keratoconus presented to our OPD with complaints of pain and watering in left eye since one day. The anterior segment OCT of patient showing tear with intrastromal clefts. Along with medical management, the patient has all these treatment options available. Looking at extent of involvement of Deskmed's membrane patient was undertaken for compression suturing and intracameral air injection. After corneal scrapping, Deskmed's membrane was sutured. Equal distance 6 sutures were placed perpendicular to the wound. Intracameral air injection was done. This is post-operative day 1 image of the patient. Day 5 patient photograph and anterior segment OCT. Patient is doing well post-operatively. Sutures were removed under asepsis in OPD after 1.5 months.
How this procedure is superior to the conventional treatment?
So as we can go for the medical therapy or the surgical therapy for the patient of acute high drops, if we go for the DM suturing along with the air injection, if there is less of the DMD that has been separated, there are better chances of visual outcomes with the help of if we correct the irregular astigmatism in the patients in future with the help of lenses. So that buys us the time also for that.
I'm talking in comparison to injecting SF6 gas in the anterior chamber.
So there's a
That
review
almost cause a resolution of acute high drop. It was done at a proper time. Here it is, you are producing, does it produce a scar?
Yes, sir. It has the remnant scar and irregular astigmatism because of the
Can
scar.
I have some late photographs, say 6 months, 1 year, to tell me how the position of cornea is?
So we operated the case in the April, so it's not been 1 year since we have operated the case.
Okay. Any literature regarding this?
Yes, sir. So there have been approximately 12 to 13 cases that has been done so far in a study that shows that if we correct the irregular.
How old was that study?
Sir, it was published in 2020, and the cases were taken from 2012 to 2018.
I'm only worried about the scarring. That was my concern.
Yes, sir.
But if you inject the SF6 at the right place with medical treatment, it does get resolved without leaving any mark.
Thank you, sir.
Who's next?
Good morning, everyone. Myself, Dr. Zeba Shine. I am presenting a video on pedicle graft. There was a patient, 67-year-old female, presented to us in the OPD. Patient has present with the complaint of pain, redness, diminution of vision, and watering for 1 month. Patient had a history of wooden stick injury 1 month back to left eye. Patient had no any other systemic or ocular history. On examination, conjunctiva was congested. Cornea shows the pseudocornea. AC had the variable depth. Pupil was irregular reactive, and the vision was PL positive and PR accurate. This is the pre-op picture of the patient. We done pedicle graft surgery done under the subtenous anesthesia. After marking the graft size, conjunctival peritomy done, and the tenon membrane tenons bluntly dissected to retrieve the thinnest possible conjunctival flap. The conjunctival flap that retrieved placed over the lesion and secured with the 10-0 nylon suture circumferentially. These are the pictures post-operatively at the first week and after 4 weeks. The AC was formed and the wound was healed and the AC was formed.
That's all?
Yes, sir.
Yeah, good. Sir. Why not to go for a therapeutic KP as a
Sorry, sir?
therapeutic
Sir,
PK as a first choice?
so in the developing countries, actually, the to find the donor tissues is very difficult. So it could be the alternative for the surgeries. Actually,
No more a problem now. Now there is a surplus in our state at least. You can and preserve cornea. You can ask for any time. That's not a well. It's a good alternative. I believe.
Why not just do a Gunderson flap instead of pura cutting and taking out a graft? Just do a Gunderson flap, pull down the conjunctiva and stretch it down.
so the vascular supply is intact in this pedicle flap actually. So the vascularization is better than that. Thank you, sir.
To a safer workplace. Of our invaluable workers are being marred by the painful consequences of the workplace negligence. At 32, this young man's journey was abruptly altered by the metallic foreign body intrusion in the cornea of his eye during his operation of iron cutting machine to slice through the iron rod. At the age of 40 of this delicate worker, a stone cutting mishap led to a foreign body's unwelcome intrusion through a corneal tear, diving into the depth of his eye, where it wreaked havoc not only in the anterior but also the posterior segment. The ocular injuries these workers face may necessitate the intricate procedures such as the corneal tear repair, traumatic cataract removal, and the vitrectomy, all entailing the intricate restoration of the damaged posterior segment and removal of the intraocular foreign body if there, as seen in this case. These intricate surgical journey, while essential for the recovery, become a formidable financial burden for those with the modest means. Promoting the awareness about the use of the protective goggles as a primary safety measure is the key to reducing these risks to a minimum, if not entirely eliminating them.
Well, this is as old as the ophthalmology is. So, what is new about this? Just I wanted to.
Just an awareness video.
What is the material of this protective glasses?
Mhm.
What
These
we
are
recommend?
carbonate glass.
No, it's a polycarbonate.
Polycar-
You see all those cricketer with funny, fancy.
Mm.
They are the one which are the most protective and most transparent. Well, it's something very basic. Even you give them 100 glasses, they will throw away all the 100. That's the problem remains. Thank you.
Yes.
Ultraviolet, infrared also. Not you. Okay. Thank you. Thank you. Hmm. Thank you, all the present. Pleasant experience. And I hope the result will be definitely announced later on, if not now. But you can collect your certificate. Reason we have not given you early, otherwise this hall would have been empty by now. You can. I think you will help them to. Please collect it. Thank you very much. Presentations, cinematic presentations.
Dr. Divya.
Yes. I hope you will find success one day.
Jyoti, okay. Jeba.
आ जाओ मैडम बाकियों को छोड़ने दो।
ये मैं करता हूँ।
They have to wait general.
Main thing is never miss the opportunities. ठीक है, make the use of it. I keep on doing it. आ जाओ, सब आ जाओ.
Sandeep can collect, so he'll get a photo also.
Yes, you can collect. That's good. एक ले लो पहले तो. Individual ले लो. एक थोड़ा पीछे से ले लो. आ जाओ, सब आ जाओ भाई. छोटे आगे खड़े हो जाओ. कुछ इधर आ जाओ. देखना आ रहे थे. हाँ.
Line things. So I start with Dr. Shanti Priya. She would be presenting here. You guys know that you have to finish up in 4 minutes, right?
Good morning, everyone. PPT.
Presentation.
Shanti. Good morning, everyone. The topic for today's class is basic terminology of strabismus. First is the binocular single vision. It is characterized by the ability to fuse the images from the two eyes and perceive a binocular depth. As all of you present here can see me and my hand singly, it means you have the normal binocular vision. It has the 3 grades of binocular vision. First is simultaneous perception, second is fusion, and third is stereopsis. To explain this, if you want to see me as a single entity, your 2 macula of the 2 eyes should perceive me as a together one single image. That is known as simultaneous perception. You should be fusing the 2 things to see as a single binocular images at the level of your cortical level. That is known as fusion. And you have to make out that there is a dais. I am standing behind the dais and there is a space between me and the dais. That is the 3D perception and the depth perception. That is known as stereopsis. Now the corresponding points. These are the areas on each retina that share the same subjective visual direction. That is, for my hand, the right and the left retina of your 2 eyes should have the corresponding 2 points that will produce a single binocular image. The next one is the horopter, an imaginary plane in the external space, all points on which stimulate the corresponding retinal elements and therefore seen singly. The parafusional area, that is zone in the front and the behind of horopter, in which the object stimulates slightly non-corresponding retinal points. This is the picture as I have given the example yesterday also. There are 3 types of student in a class. Type 1, that is the horopter, attends every class, the toppers of the student who comes on time, passes the exam with graceful marks, comes under horopter. There will be always a production of clear, better image in the presence of horopter. Type students like me, who sometimes bunks classes, goes with their friends to do some masti also, but in the end they pull off well and pass the exam. There will be slight non-corresponding points present, but still the image will be clear. that will come under Panem's fusional area. And type C students who will not come to the class, not attend the classes in the end also, and gradually will fail the exam and produces diplopia. Next is orthophoria, that is a perfect ocular alignment in absence of any stimulus. Heterophoria, that is the tendency to deviate. If it is inward, it would be esotropia, and if it is outward, it would be exophoria. The tropias, that is a manifested deviation in which the visual axes do not intersect at a point of fixation. That may be horizontal and that may be vertical. Horizontal esotropia is the inward deviation, exotropia outward, hypertropia the upward deviation, and the hypertropia the downward deviation. Next is the fusional vergences. These are the disconjugate eye movements to overcome the retinal image disparity. For example, if we want to see the farther objects and we want to see the near objects, our eyes has to converge. That comes under the vergence movements. The suppression, active inhibition of the visual cortex of the image of one eye when the both eyes are open, and abnormal retinal correspondence when the points are focused on fovea doesn't correspond to the fellow eye. Thank you.
Good afternoon, everyone. Welcome to the revision class. So we learn about approach to fourth nerve palsy. Coming to the introduction, so we can see clearly the annual incidence is 5.73 per 1 lakh per year, and from our anatomy classes I told you it is the only cranial nerve to cross completely on the other side, arising from the dorsal aspect, and longest and thinnest of all cranial nerves, etiology being congenital and acquired. So we have a patient in our OPD, a 12-year-old male, presenting with complaint of upper deviation of right eye since childhood with no other significant history. We'll come back to this after learning the approach. So coming to the approach, these are the salient points and the sequence we follow, starting with the history, how the patient presents. So here we have a child also and an adult also, clearly demarcating the congenital and acquired palsies. In congenital, we'll have a facial asymmetry due to the head tilt or the posture that the patient has all through the ages. And in acquired cases, we'll have torsional or vertical diplopia associated with contralateral head tilt. Coming to old photographs. Now my class, can you tell me how old photographs will help? Yes, in congenital cases, all through the ages, all the tilts will be present. So this head tilt is present in all through the ages of the child. Coming to squint workup. So the most important test is the Parkes 3-steps test. What are the 3 steps, my class? So first step is a deviation in primary gaze, deviation in levoversion and dextroversion, and the third step is tilt. So here we can clearly see worsening left hypertropia in primary gaze, worsening in dextroversion, and we have a diagnosis of right head tilt and left SOP. So always remember contralateral head tilt since the torsion doesn't work. But my friends, don't miss the other eye, especially in case of trauma wherein there is damage to the point of cross section. So these are the salient points. We have positive head tilts in both the directions and V pattern, esotropia, chin depression, and greater than 10 degrees of extraocular torsion on Maddox rod. Coming to torsion, so how we assess it? There are 2 methods, subjective and objective. Subjective by double Maddox rod and objective by indirect ophthalmoscopy. So here we can clearly see the subjective and objective methods of assessment of torsion, followed by investigations and neuroimaging. But then the confusers, ocular myasthenia, thyroid eye disease, and other orbital diseases. Coming back to our case. So this is the summary of what our case presented with. This is the BCVA, the extraocular movements in 9-gaze clinical picture with IO overaction, PBCT, fundus photo clearly showing right eye extorsion. So we made a diagnosis of right eye congenital SOP with IO overaction. Now this corresponds to class 1 NABS classification. We went for Enlade-Hankins procedure, and these are the post-op photographs. So time for quick recall. Quiz time, my students. Head posture in left SO palsy. Anyone? Yeah, correct. Right head tilt. Thank you.
I'm just giving them a hint. You see, you are a teacher now, and if you are so fast, none of your students will follow it. So, be brief, but you must pass on the message that the students can really follow it. What you have read is so fast, I cannot follow it, and most of the students sitting. So, being a teacher, you should be slow and see that you get a response, that they are really perceiving it. It is not a presentation in a conference that you have to fill the slides fast, in time, whether the audience understand or not. You are a teacher now, and you must see that students are following it. So don't be so fast in teaching. So Kavita is here as a HOD. If she teaches you in this way, none of you will follow. And the subject like this one, you showed the photograph. You did not explain any of the photographs. There should be explanation. I mean, I'm just, so when you are presenting or teaching, the teaching should be in a way, it should be understandable, little slow, maybe the content you can take another class. It is not a must that you finish one subject in one class only. So this is how, I mean, this is the purpose of the session. Thank you.
I agree, sir. So we have Anshika now. She'll be presenting on gonioscopy.
Good morning, class. Let's revise yesterday's class. We started with definition of gonioscopy. It is method of evaluating anterior chamber angle. Principle, light from angle structures undergo total internal refraction, so we don't see them normally. Without any lens, we can't see angle structures. So we need a gonial lens. Refractive index of cornea is more than air. That's why we are not able to see angle structures. But when we place a gonio lens, its refractive index is equal to or almost equal to cornea. Therefore, total internal reflection is eliminated and we are able to see angle structures. Cleaning of lens, I have explained. We have to soak in 2% hypochlorite solution for 5 minutes, followed by thorough rinsing, then air drying. This is most important for postgraduates. Technique, first of all, we'll explain the technique to the patient, what we are going to do and why we are going to do. Then we'll make patient comfortable on slit lamp. We'll explain the procedure. A drop of local anesthesia is placed. Coupling fluid is placed on the surface of lens. Only some lenses require coupling fluid, which I'll explain later. Ask the patient to look upward. As the patient will look upward, we'll hook in lower fornix and then we'll ask the patient to look straight. Okay, methods of gonioscopy, we haven't discussed this much yesterday, so we'll discuss this more. Direct gonioscopy, Coppe lens. In this lens don't have any mirror, so we can see directly angles. Indirect gonioscopy with indentation or without indentation. With indentation, we give a little force and we can differentiate between synechial and appositional closure. Other lenses, Goldman 3 mirror, which we all must have seen because as a postgraduate, we almost all have Goldman lenses. Posner 4 mirror lens, Sussman lens. Angle structures, this is most important. We'll move to next slide. See, there is corneal wedge where the anterior and posterior reflection of slit lamp will converge. That is the place Schwalbe's line. This is most important for us identifying the Schwalbe's line because it will help us to differentiate between open angle and angle closure. As a postgraduate, we'll not go for diagnosis. We'll just learn the structures properly to identify the structures. See, this is open angle. As in the left side, we can see all the layers of angle. And next, second slide, you are not able to see any layer. And after iris root, directly no layer is seen. So it is a closed angle. In this case, we can go for indentation gonioscopy. Schaffer's grading, lesser is the grade, closed is the angle. More is the grade, it is open. Grade 1 and grade 2 are susceptible to angle closure. Grade 4 is mostly open. See, this is a double hump sign. Few diagnostic pictures. Double hump sign seen in plateau iris. Most prone to angle closure. This is a picture of trauma, post-trauma picture, gonioscopic picture. There is cyclodialysis. Iris has been uprooted from its root. This is also another trauma picture. There is blood in angle. Okay, thank you.
So next we have is Simran. Any questions judges can ask if they want? Okay, so we move on to the next talk. Simran.
Good afternoon, everyone. Today I'm revising a very basic class, aqueous humor dynamics. Aqueous humor, it's a very clear, colorless, watery solution which helps in the maintenance of intraocular pressure, have metabolic role, optic function, clearance function. The volume of aqueous is 0.3 ml, out of which 0.25 ml lies in the anterior chamber and rest in the posterior chamber. Now the aqueous humor production is by the ciliary process, which is a part of pars pliccata. Formation process involves diffusion, which is in the direction of concentration gradient, ultrafiltration, which is limited by size and charge, as we can see. Secretion, which is an active process, it requires ATPases. So basically it is going against the concentration gradient. Now it have to pass through the 3 layers of ciliary process. First, from the endothelium, it goes into stroma. From there, it goes into pigmented layer, and then into the non-pigmented layer. Steps of aqueous formation. First, there is a formation of a stromal pool. Then there is an active transport of the substances, and then the passive transport from the non-pigmented epithelium. Now, how this stromal pool formation occur? First, there is a substance passes through the capillaries of the capillaries to the stroma, and then they go behind the tight junctions of the non-pigmented epithelium. Now, this fluid which has been formed, they goes into the anterior chamber. Now, the aqueous humor, which is lying just below the cornea, because of evaporation, it become cooler, and the cooler fluid, they are more denser. So because of dense fluid, they go downward, in contrary to the aqueous fluid which is present the aqueous fluid which is present just above the lens, it is warmer. So it creates a temperature gradient, and because of this temperature gradient, there is a conventional flow of the aqueous humor. Now drained out through 2 routes, uveoscleral and trabecular meshwork. Now uveoscleral outflow, it from the anterior chamber, it goes into ciliary muscle and then to the suprachoroidal space directly into the venous circulation. In the trabecular outflow, maximum drainage occur through this route. So first it passes through uveal meshwork, then to the corneoscleral meshwork, and then to the juxtacanalicular tissue. From there, it goes into a Schlemm's canal, inner wall of the Schlemm's canal, and then directly into the episcleral vein through aqueous vein, or indirectly through intrascleral vein. Now during diastole, what happens is there is decrease in the intraocular pressure. Because of that decrease in the intraocular pressure, this trabecular meshwork, it is pulled inwards. So it creates a negative pressure over there. And this negative pressure, it sucks the fluid from the aqueous vein into the canal. And in the systole, there is an increase in the intraocular pressure. Because of that, the trabecular meshwork, it is pulled outward, and because of that positive pressure, the fluid goes into the aqueous vein and then into the episcleral vein and then to venous circulation. Thank you.
Any questions from judges, or should I call the next one? So we have next Dr. Vanshika. Next is Dr. Darshana. Yes.
Good morning, everyone. Today we will study about OCT biomarkers in diabetic retinopathy. Diabetic retinopathy is a vascular disease which affects deep retinal capillaries, and there are many vascular changes seen due to changes in deep capillary plexus, and these vascular changes lead to many structural changes, mainly in the macular region, which are detected on OCT. Now, what are OCT biomarkers? These are non-invasive, helps in the refinement of diagnosis, provides near histological assessment, so are useful to study disease progression, are reliable, accurate, and are important to assess functional outcomes of the treatment given to the patient. First is central subfield thickness. It is defined as thickness of the central 1 mm area circle in ETDRS grid map. In cases of diabetic macular edema, this retinal thickening occurs and this thickness increases. Now, when retinal thickness exceeds the retina stretching capacity, it leads to damage to bipolar cells. Bipolar cell snap occurs, and these bipolar cells are important for visual signal transmission from photoreceptors to ganglion cells. And due to this damage, there occurs reduced visual signal transmission, and hence the visual outcomes may be suboptimal even after the resolution of diabetic macular edema. So this raises a question that whether alone central subfield thickness is enough to predict the visual outcome. No, we need other biomarkers. So the first is DRIL, disorganization of inner retinal layers. It means that the four layers GCL, IPL, inner nuclear layer and outer plexiform layer are not distinguishable in the central 1 mm of fovea. So even if edema is resolved and DRIL is present, visual outcome will be poor post-treatment. Next is hyperreflective foci. It is formed due to breakdown of inner blood retinal barrier. Some studies believe them to be extravasated lipids, while others believe them to be activated microglial cells. Microglial cells are inflammatory cells, hence it is an important inflammatory marker. Sometimes it arranges in the form of a circular around a cyst, giving a pearl necklace sign appearance. Now, how to differentiate them from hard exudates? There is no backshadowing, size is less than 30 micrometer, and reflectivity is very much similar to RNFL. And in patients who have higher number of hyperreflective foci, there are chances of earlier reoccurrence of diabetic macular edema. So frequent follow-ups are needed in these patients and early intervention is recommended. The next biomarker, which is also formed due to breakdown of inner blood retinal barrier, is intraretinal cystoid spaces. Sometimes there is accumulation of hyperreflective material around in this cyst, which is composed of fibrin and inflammatory debris, and it indicates long-standing edema. So it is a poor prognostic indicator. Next is bridging retinal processes. These are vertically oriented hyperreflective lines representing residual neural elements composed of Muller cells and bipolar cells. And if they are absent, it means that the prognosis will be poor because no visual signals will be transmitted from inner retinal layer to outer retinal layers. Next is ELM EZ zone disruption. The integrity of outer retinal layers is very important for visual signal transmission. And if these are disrupted, it means the visual acuity will be compromised. Next is OCT angiography. It is preferred over fundus angiography because all the three capillary plexes are seen individually in different slabs and no dye is injected in these cases. So if no dye is injected, it is safe in renal function impairment patients, in pregnant patients, and there is no risk of anaphylaxis. The take-home message is that OCT is a good imaging biomarker. It is non-invasive. Central subfield thickness, which was believed initially and was used very widely by us, has only modest correlation with visual acuity. But the new biomarkers which we have studied are robust predictors of visual acuity in diabetic macular edema and help to counsel the patient accordingly. Thank you.
So next is Dr. Darshana Parihar. And then after that, we'll have the last, Dr. Vignesh. Is he here?
Good morning, class. So today's topic is corneal blindness and eye banking, current strategies and the best practices followed. So we all know that corneal blindness is a leading cause of blindness globally as well as in India. What are the major causes of corneal blindness? We see a lot of patients of corneal ulcers and infectious keratitis in our ward, and the other causes are corneal trauma, pseudophakic bullous keratopathy, chemical injuries, keratoconus, infective conditions like trachoma, and hereditary corneal dystrophies. Okay, so let me tell you about the Transplantation of Human Organ Act 1994. So it was implemented in 1994 and it was modified in 2011 to Transplantation of Human Organ and Tissue Act, where cornea is considered as a tissue and not an organ. So under this, the relatives are also allowed to provide consent, and not only the registered medical practitioners, but trained technicians can also retrieve cornea from the deceased. Now, what are the consent systems which are followed in India? One is opt-in system and another is opt-out. In the opt-in system, we have to voluntarily donate our eyes. And in the opt-out system, which is not followed in India, everyone is considered a donor who doesn't opt out. Now, what are the two ways to procure corneal tissues? One is voluntary eye donation, where the deceased family has to inform the eye bank and the trained technician will go and collect the cornea. And in the HRCP, Hospital Cornea Retrieval Program, a trained grief counselor is assigned at every hospital. And whenever a person dies at the hospital, the
counselor attends the family and counsels for the donation of the cornea. Now, can anyone tell me the advantage of HRCP over VED? So it is that we already know the medical history of the patient. Now, what is an eye bank? It is a non-profitable community organization, and its function is to harvest tissue, evaluate the tissue, tissue preservation, and tissue distribution. It also helps in research and public awareness. In India, there is a 3-tier system which is followed. Eye banking training center is there, then eye bank and eye retrieval centers are there. Now, who can donate cornea? Person of any age and sex can donate. Post-cataract surgery patients can also donate. Patients of diabetes and hypertension and patients of blindness of retinal or optic nerve origin can also donate. Now, what are the contraindications? They can be ophthalmic and medical contraindications. Any previous anterior segment surgery or corneal pathologies like dystrophies, opacities, keratitis, and any intraocular tumor like retinoblastoma or malignant melanoma, and active intraocular inflammations are also a contraindication. And what are the medical contraindications? It involves active infections like AIDS, hepatitis, bacterial and fungal infections, and active leukemias and lymphomas, etc. So this is a cell check Conan specular microscope. You all must have seen it in our ward, and it is used for donor cornea tissue evaluation. So it views epithelium, intrastromal structure, and endothelium. We all must know how to operate it. Now, preservation media is divided into 3, which is short-term, intermediate, and long-term storage media according to the duration for which the cornea is stored in them. Now, I want you all to tell me about the content of these storage media in tomorrow's rounds. Okay, thank you.
Good morning, everyone. Our today's class will be about evaluation of visual acuity in infants and children. In this session, we will skim through the visual milestones and assessment of visual acuity. Before we start, we need to have an idea of the visual milestones. So, what test we have to provide to the children and the response expected. As you can see in this chart, that before 3 years of age, a child starts with fixation towards light and then following its favorite pictures. However, after that, they can give a normal visual acuity test. But what are the challenges faced? Children have sudden change in mood, they have a very low attention span, the stranger's anxiety, and the inability to understand the need for examination. So we are going to study set of 8 rules to collect visual data from our mischievous little humans. There will be rule number 1. Since you have given them old pediatric trauma with needles, it's time to remove the coat and become friendly. Then rule number 2 is for ourselves. We need to, knowing the age is must to provide the right environment for further evaluation. Infants less than 2 months of age only react to mother. However, after that, they might react to your gestures. Children from 1 to 3 years of age are joyful around toys, and after that, their visual acuity can be graded as a standard visual acuity charts. Now, rule number 3 is initiate. In this, examination divided into 2 types of segments. There is sensory motor examination, which is a binocular one, not involving any interference to the child, and child is least resistant to it. However, the second would be the motility examination or the monocular one. Then let's learn the art. The sensory motor examination in infants, fixation testing. Fixation of light is the first thing that a child develops, and after that we can go to our CSM method, that is central stands for central corneal reflex, S for steady eye movements, and M for maintained eye movement. Then we have the optokinetic nystagmus drum, a vintage and useful instrument to find breaks and saccadic eye movements and know about the visual acuity. Then children 3 to 1 month of age test based on spatial frequency of images. Here we have our preferential looking test that are teller acuity cards. Here stripes, black and white, are on one side and uniform color on the other side. The stripes keep on decreasing cycles per centimeter, and as soon as a child loses track, we keep a record. And in the rule number 6, we recheck our mistakes and interpret it according to the standard Snellen's chart. Here we can see the Leah grading test working same as the teller acuity cards, and just there are paddles for this. Then the Cardiff test or the vanishing optotype. Here outlines of known figures are shown to the child and they keep on fading on subsequent cards. So if you cannot read the last line of this test, sorry, you haven't passed the Cardiff test. Next, we have children or the notorious gang. Here we have the Leah symbols for 1 to 3 years of children. They are common images of apple, house, window, and ring, and visual acuity is noted as per Snellen's or Logmar. Next, we have the HOTV testing, and the third, we have the pediatric charts to keep them busy in a boring ophthalmologist room. Now, older children, linear letter optotypes are used, standardized tests for evaluating visual acuity. Here, placed at a distance of 6 meters or 20 feet. Each letter subtend an angle of 5 minutes, grade from 660 till 66. Here we have the Snellen's, the Logmar table, and the third, the Landolt C, the oldest method. Now, what if the child visual milestone is suboptimal or deficit in cognitive development? We have to go to a rule number 7, that is enable the disabled. And here we have the visual evoked response and the Steiker test, in which there are 7 common letters that are written, and a key card is handed over to the child. And we see if the child can match to the letter in the cards. Rule number 8, never give up and keep smiling. It's okay to be a grown-up child, and we need to follow the rules of children. All right.
So this
Thank you
finishes
so much.
with the presentation round. Now we move on to the extempore round. So what we will do is you'll have to pick up a chit, and then I'll announce the topic. You'll be given 13 seconds to group and assimilate and organize your thoughts, and then 2 minutes extempore would be here. So you'll be shown the time mark here on the screen. So I'll start with Shanti Priya. You can pick up a chit and let me know what is your topic. So she gets lens-induced glaucoma. So 30 seconds for you to think about. Timer लगा दो. 30 seconds. Still have around 10 seconds more to think about. It's okay.
Okay, topic for my today's is the lens-induced glaucoma. First, I would like to imagine you this closed room as a space. If there are 3 structures present in this closed room, if one of the structure is progressive like anything, if I am getting fatter and fatter, what will happen to you? You all will be compressed, and the pressure of the system will increase. So that is exactly what an lens-induced glaucoma look like. The lens get hypertrophied. There is a production of the antigens that leak into the aqueous, and there is a rise in the IOP of the eye. So what can be the preferential treatment? First, medically, I have to give this room some time so that it doesn't explode. I will do it by buying some time with the help of some anti-glaucoma drugs. We can use any kind of anti-glaucoma drugs that will be oral, that is tablet Diamox 250 milligram, that can be used QID, and with some topical medication. The topical medication of the anti-glaucoma drugs will be given. We can start with the beta blockers or the combination therapy. And after that, the patient can also be given IV mannitol to decrease the IOP of the patient to certain amount of time, and the patient will be taken for the cataract surgery. In the cataract surgery, we have to ensure a few basic points. The first one is that IOP of the patient should be controlled, and in order to minimize the inflammation, we will be also starting with topical steroid therapy to the patient. Secondly, during the operation of the patient, during the surgery of the patient, we can also go for the viscocohesive, viscoelastic substances such as Viscoat is available in the market. Thirdly, because of the high raised pressure of the eye for prolonged time, there will be high chances of the complication. The complication can vary from simple lens zonular dialysis to the suprachoroidal hemorrhage that has the extensive cases have been seen with lens-induced glaucomas. And thirdly, after that, when we'll be planning the surgery of the patient, the post-operative steroids and the post-operative anti-glaucoma therapy has to be given to the patient to maintain the pressure of the eye. Thank you.
And she gets his retrobulbar neuritis. 30 seconds.
Good afternoon, everyone. So my allotted topic is retrobulbar neuritis. So when it comes to neuritis, we can have three presentations basically: optic neuritis, retrobulbar neuritis, and neuroretinitis. They differ clinically also, and as well as in pathology also, the way they occur. So optic neuritis, in optic neuritis, we'll have the symptoms of optic nerve involvement, like RAPD will be there, contrast sensitivity, color vision will be reduced, but then there will be an optic disc swelling also associated. If we come to neuroretinitis, we'll have a macular star. But when it comes to retrobulbar neuritis, we'll have no clinical signs of optic disc edema or optic disc changes. We'll only have the symptoms that the patient comes with: low vision, low contrast, low color vision, RAPD, etc. So for retrobulbar, that is posterior to the bulb, so we need to go to the back of the globe and go for an imaging. So after getting the imaging done, we'll go for a contrast enhanced MRI done, and we'll see the optic nerve thickening and enhancement, and accordingly we'll have the management. So coming to the management depends on the imaging that we have. In acute presentation, we need to start the patient with steroids. If this acute episode is not being controlled, then the patient can, since they can be missed by the clinicians if not comprehensively seen by the doctors, so they can produce optic atrophy later. So this can lead to permanent visual loss if not treated adequately at a paramount time. Thank you.
Now next is Dr. Akshika. She'll be talking on congenital NLDO. Simran, you can come. And I'll ask you in the last 30 seconds to pick up your slip. 2 minutes.
Good afternoon. Topic of our class is congenital nasolacrimal duct obstruction. Suppose a patient comes to you, patient will not come to you, his attendant will come. मेरे बच्चे की आंखों में से पानी बहता रहता है. This is the most common complaint that comes. And we almost ignore moxi CMC दे के भेज दो, कभी ना कभी सही हो जाएगा. This is major ignored topic. So we'll work up the patient. As the patient will come, first we'll check for blocks. We can check with fluorescent dye test, syringing, probing syringing can be diagnostic also and therapeutic also. We'll ask for the history and age of the patient, which is very important because we will manage according to age and according to history. If there is any pus discharge or any other infective pathology, we'll not directly go for syringing probing. So patient will come, we'll do diagnosis. Now we have made a diagnosis. Now treatment. If a child is less than 2 years of age, less than 1 year of age, we'll go for nasolacrimal duct massage, which is very important. Patient को अच्छे से समझाना है और उसकी language में समझाना है कि इधर जाना है, बिल्कुल ये अपना फील करेंगे, ये बोन उनको फील होगी और यहाँ से नीचे जाते जाते ऐसे प्रेशर बनाना है दिन में 3 से 4 बार. दिस इज द एग्जैक्ट वे हाउ वी शुड एक्सप्लेन टू द पेशेंट और करके बताना है. ऐसे नहीं है कि यू एक्सप्लेन इन इंग्लिश एंड पेशेंट इज नॉट एबल टू अंडरस्टैंड. देन नेक्स्ट we can do syringing probing for child under GA. We have to do syringing probing. Nasolacrimal duct probes are present. Nowadays we don't have to measure. Firstly we measured up to 4 mm, but now we don't have to measure. Auto marked probes are there, so we just feel the punctum and do probing. Okay, thank you.
Thank you, Akshika. So next we have is Simran Kaur. She'll be talking on pars planitis for 2 minutes. 2 minutes मैं लगा दूँ.
Good afternoon, everyone. My topic for today is pars planitis. This I have already explained in my PPT what the pars plicata is. The ciliary the body has two parts, pars plicata and pars plana. So infection, as the name suggests, itis, it's basically the infection of pars plicata part. So because of this inflammation, there will be increase or there will be disturbances in the intraocular pressure. जो भी प्रोडक्शन हो रहा है उसका एक्वस ह्यूमर का, उस सब में इफेक्ट आएगा. uh, in the past plicata we have to do the slit lamp examination और इस slit lamp examination में हमें cells देखनी है कि कोई cells तो नहीं है वहाँ पे anterior chamber में कोई cells तो available नहीं है जिस और in this we will give the antibiotic treatment and steroids if needed. Thank you.
So Vanshika has intraoperative small pupil. So she still has around 10 more seconds to think about. Okay. If they want, they can think, they can jot down whatever. So 2 minutes for you, Vanshika now.
Good morning, everyone. Today's topic is intraoperative small pupil, that is miotic pupil. Before doing any surgery, that is important cataract surgery, we have to dilate the pupil. In ideal conditions, we dilate it using tropicamide plus phenylephrine. Full dilatation is very important for the easy delivery of the nucleus and for lens implantation. But in some patients, the pupil is not dilated properly, like in diabetic patients or who are the patients, BPH patients who are on tamsulosin, they have floppy iris syndrome. So in that cases, pupil is not completely dilated with the dilator. So we get a miotic pupil while surgery. It can lead to many complications while doing surgery. The first of all, when we have to deliver the nucleus, it will be very difficult for us to deliver the nucleus, and then lens implantation will be difficult. So we can deal with with it in different ways, like intraoperatively we can use mediatric agents like phenocaines are available, tropicamide plus phenylephrine or ADRs can be used to dilate the pupil. Then we can also use hooks are available to dilate the pupil. And in some cases, pupil is dilated initially, preoperatively, but as intraoperatively we are doing phaco, and when the phaco prop touches the iris, it constricts back, and then we have to dilate it again for the procedure. And especially if the beginners like us have to see the case properly, that if there is a preoperatively pupil is not dilated, pupil is small, we have not to take that case because it can lead to many complications during the surgeries. Thank you.
Next we have is Dr. Darshana.
So I'll be talking about retinal detachment. Retinal detachment is a condition, clinical condition, in which the retina it detaches from the support support of the eye, and it is of three types. One is rhegmatogenous, another is serous, and one is tractional. So the most common type is rhegmatogenous retinal detachment, in which it is most commonly associated with, it can be age related also, and in it there is retinal tear or holes which can be seen, and fluid accumulates beneath the retina and the choroid, and we have to for the workup we have to do all the examination like fundus examination, slit lamp examination, and then we have to decide the management, which can be surgical management, or it can be PRP also, photorefractive procedures also we can do, and surgically we can manage it by doing buckling, scleral buckling surgery, or we can also do vitrectomy, PPV plus silicone oil implantation, or we can also use SF6 gas, and we have to instruct the patient to lie down strictly in prone position post the operation, and that's it. Thank you, sir.
Last we have is Dr. Vignesh. He gets endothelial keratoplasty as his topic. Endothelial keratoplasty. You just want this to be changed? Yes. Okay. So you can pick up again. We'll give you another 30 seconds. So now he gets RAPD. Just think about it for 30 seconds and then you can.
Right, my topic is RAPD. What does RAPD stands for? Before that, we need to know why we see RAPD and where to see RAPD. What is RAPD? The black part that we see our pupil, that is what will give us that what is RAPD. RAPD stands for relative afferent pupillary defect. Normally, whenever we show light in pupil, there is a reflex that on light the pupil constricts, and when in dark it dilates. And whenever we even on other eye we show light, then other people constrict. That is a consensual reflex. There are two types of reflexes: direct and the consensual reflex. However, in RAPD, whenever we do a swinging light reflex, that is, we move our torch from one eye to the other eye, rather than constricting, the pupil starts dilating. This gives us the idea that there is a damage to the sensory nerve, that is optic nerve, since it is taking the sensation through the light and it's constricting by the oculomotor nerve. Therefore, we evaluate it further. RAPD is seen in cases where there is optic nerve damage, such as in cases of glaucoma, and it is seen in cases of optic neuritis or papilledema. When there is high-grade papilledema, there will be damage. All right, thank you so much.
Thank you everyone for the presentations and extempores. I hope you all enjoyed. Just wait for a while. We're going to total the marks and then probably we'll declare the winner and the prizes, whatever they have been kind of planned.
Before the things, retina is not getting a support. What is it? What is detachment? Is it separation between sensory retina and this is not the support alone. Okay, and then I mean, being a resident, you can't do that justice to the subject, but you must tell the basic. As I mean, to the you are teaching, suppose an MBBS student or an MSS student. You must mention, if you are teaching a MBBS student, what is the detachment is and what is the basic principle of making the patient comfortable or reattach it. Basic principle. How do you do it? It's a different thing, but basic. Similarly, like lens-induced glaucoma. Somebody who was lens-induced glaucoma. You see, you said the increase in the size of the lens increase causes. Is it only the cause? Lens-induced glaucoma, you should tell that it's just not a primary glaucoma, it's a secondary glaucoma. Secondary glaucoma, because of the lens, can occur because of 1, 2, 3, 4 mechanisms. And then the treatment lies. So, don't be in a hurry. You see, as a teacher, you have to prepare yourself. When I teach postgraduate students, I really have to go to the books, to the net, get the latest information, assimilate it, and then teach, because it is for everybody. But then don't be in a hurry to jump and leave the things which are important. This, I mean, am I right, sir? Aapko, if you have to take the subject in 1, 2, 3 lectures, do it. But taking all the things together in a one lecture, which when you are not able to really tell the students what is the subject and how it is to be dealt. So the format is.
So we have started this session for the first time. So we'll.
I think it's very well conducted, and they did a great job when considering that they are, obviously. I mean, it's like they're playing a teacher. They're not yet teachers. They're still learning, and I think they did a great job, and they should keep the enthusiasm. alive and probably do better. But I think they did a great job considering other states and all that. Kind of participation here has been very encouraging. Yes. And the second? So, yeah, I think all of them are winners. They came to the finals anyway. But according to the judges, the first prize winner is Vanshika, and the runner-up is Tapasya.
Way you were telling is the right way. Slowly and make the students understand. This is what the purpose of this one. Because all of you can contribute a subject in a very good way. Good way of all.
So the winner will get, of course, a prize at the inaugural ceremony in the next conference. So be present at the Udaipur conference 2024, and you are getting a AOS registration and travel from ROS of Calcutta 2024, and you will be the team representing Rajasthan in the TOT program of AIOS also.